All right. Hi, I'm Jim Webley, and welcome to Rule of the Ring. You know, when you talk about orthopedics, it's often sort of a pattern recognition thing. So what do you think these two fractures have in common? And probably lots of things, but one of the most important things is they both obey the rule of the ring. So what is the ring? Well, the ring is in the forearm and the leg. It's the both bones that are connected in a ring-like structure that holds them together. So they're tethered at each end by very powerful ligaments, and then their interosseous membrane connects them along their length, and then they act as a single unit so that they do everything in unison. This is, of course, true in the leg too, with strong ligaments at both ends and the interosseous membrane making one ring out of the structure. Well, you know from taking rings off people whose fingers have swollen that making one cut in the ring doesn't make it unstable. It's that second cut, the second piece of damage that makes it unstable. And that is sort of the essence of the rule of the ring. They act like one unit, and it takes two breaks in the ring to make them unstable. So the rule is, in the forearm and the leg, one bone cannot be displaced without displacing the other. And the key is that word displacement. To displace one, you have to have done something to the other one to break the ring. So we'll look at a few examples of this. So here is a fracture that's obviously displaced on the radius. And of course, the ulnar has a similar displaced fracture. The fracture line goes through the interosseous membrane, etc. Very, very classic rule of the ring. Here's another with a displaced fracture. The ulna and the radius also is displaced. And so there are two breaks. The rule of the ring is applied. Here is a very slightly more subtle one with a obvious displaced fracture of the tibia, but the fibula also is fractured and displaced, and so the rule of the ring applies. Well, what about this, the little Taurus fracture out here? Where does the rule of the ring apply here? Well, a Taurus fracture is the axial compression of a pliable bone, and pliable being absolutely the key word. They typically done from these absolutely nothing injuries. A child running and falls down a single step. The mechanism sure sounds like nothing ought to have happened, and yet the child won't move the arm or leg because it hurts. They don't swell, they don't get ecchymotic, and it's very unobvious sometimes. The way I like to explain this to parents is if you take a Dixie cup or a cup and you compress it axially, it'll bend and crinkle, and that's what you're seeing in the bone. You're seeing sort of this crumpled bone. And the reason this happens is the diaphysis here. Notice how much thicker than that is the metaphysis up here. And so when you sort of smash the diaphysis into the metaphysis, the weak point is somewhere in the transition, and the bone crumples there. There's some microfractures, and the buckling happens right there if the bone is supple enough. By the way, just for fun, here's a column, and this is the Taurus part of it. And notice how that looks vaguely like the fracture that we're describing. So that's where it comes from, not from the Taurus car or the zodiac sign. So here's our Taurus fracture, that when you have a child and a metaphysis injury and a crinkled bone, then that's likely to be the Taurus fracture. Now, do Taurus fractures obey the rule of the ring? Well, one bone cannot be displaced without displacing the other. And the key word there is displacement. Is there displacement of this? And no, there isn't. So the Taurus fractures obey the rule of the ring by not obeying the rule of the ring. You know, is this anything more than just nonsense about Lord of the Rings? Well, I would say actually there is some applicability to what we do. And let's look at a quick example of it. Here is a fracture dislocation of the tibia. And from that, we know there must be something wrong with the fibula. Somewhere in there is damage and displacement. Where is it? And it turns out to be up here, which is, I think, very unobvious. We will get a lateral view, and we'll know to look for part 2 in the lateral view because it's somewhere there. Distal, proximal, it's somewhere in that bone. So we know that the rule of the ring tells us part 2 is somewhere. We haven't seen it in the AP. We'll find it in the lateral because we know to look for it. So we're going to go on a little gallery, a little tour of some of these problems and places where the rule of the ring could actually help you. So we'll start with this fracture dislocation of the distal radius. And we know from the rule of the ring that there must be a part 2. It's got to be in the ulna. So where is it? The most common of the subtle fractures is Galiazes. And this is a fracture of the distal radius and a dislocation of the distal radial ulnar joint, or the DRUJ. They can occasionally fracture the styloid, not essential. So here's a look at the patient we saw before, their distal DRUJ. And notice the Galiazes on the left as opposed to normal on the right. Notice that the widened area here is much too wide compared to on the right. And then the normal line there does not line up on the left. And so you have disruption of the DRUJ and essentially a dislocation. So back to our original problem, we have the fracture of the radius. Where's part 2? It's got to be in the ulna. And here it is. The ulna is much too long. It's slightly displaced. And we have a dislocation of the DRUJ. So you have a fracture of the radius, dislocation of the distal joint, and that's the combo that makes up Galiazes injury. Well, the mechanism of this is in some form a Foch injury, and there'll be deformity at the distal radius, tenderness at the DRUJ. And then they can come in lots of forms. Here's a real obvious one with a big displacement here, and look at the widening of the DRUJ. There's a little dorsal displacement, and so this is really obvious. I mean, nobody could miss this. A little more subtle one, here we have a fracture with displacement at the distal radial ulnar joint. It's too wide. Here in the lateral, notice that the radius and ulnar really don't line up. So the not only is the DRUJ widened, but it's a little dorsally displaced. So a little more subtle, but certainly something you can find. In adults, immobilization and surgery is the treatment for these. These all will get surgery. In children, occasionally they don't. It's much more of a judgment call because sometimes they will do well. Well, when you have a Foch injury and a fracture of the distal radius, if there's tender over the DRUJ and there may be deformity there, think about Galiazes injury. That combo is important. Now, Montaicious injury, don't you love that we have all these useless eponyms? This is great, right? Montaicious injury is the mirror image of Galiazes injury. And here we have a fracture of the ulna with displacement. We know there must be displacement of the radius. Where is it? And it turns out that the radius is not aligned, or it doesn't articulate with the capitellum. So there is a dislocation of the proximal radius. That's part 2. So Montaisia injury is a fracture of usually the proximal ulna with a dislocation of the radial head. So those are the 2 parts of the rule. So it's typically a Foch injury, but it can be hyperextension in children, and a direct blow to the ulna is not terribly uncommon. And I'll show you an example of that I ran across some years ago. Well, the proximal radius should articulate with the capitellum in every view. So when you draw a line down the radius, it intersects the capitellum in every view, right? I mean, you've heard that before. Here's the radius. Well, it's sort of bowed, right? I mean, hold on. How do you draw the line down the radius? Well, here's a line down the radius. Here's a line down the radius. Here's a line down the radius. Which one of those is the one that intersects the capitellum? Well, I think it's important to remember that typically the radius has a 15-degree bend right when it turns from the neck into the metaphysis. And this is what gets a lot of these lines screwed up. So we keep that in mind. We know we have to be right in the distal radius. So if you draw a line that is parallel to the actual, the head or the articular surface, like such, and then the perpendicular down the neck, that's the one that ought to intersect the capitellum in every view. So you have to sort of remember that this is a bowed structure, that neck is at an angle. So go to the actual place where it's articulating and draw that perpendicular, and you'll find that's the one that you need to have. So here we have a nice look. We got a fracture here of the proximal ulna. And if you draw a line down the long length of the radius, you can see, well, maybe that intersects the capitellum, right? Sort of, yeah, maybe it gets in there anyway. But if you draw the perpendicular to the articular surface and now draw that, I'm sorry, the parallel, and now the perpendicular to it, you'll see it's a clean miss. And so it makes a difference how you draw that line so that it doesn't become an arbitrary thing. Okay, so here is a very bad Muntasia injury with a lot of deformity, but we have the radius intersecting the capitellum beautifully. Remember, it's got to do it in every view. And here's the lateral caused by a blow to the a medial blow, and you can see that there is a clear miss here. So it's got to articulate in every view. So in general, Montaicious injury, and the reason it's got an epidem is because it has very poor results in general, especially for adults. So for adults, it's long arm immobilization in the emergency room and referral for surgery. They're all going to get surgery. In kids, a little different. They'll often do a closed reduction. As a general rule, I think this doesn't belong in our bailiwick. This is a call orthopods and let them do the reduction. But occasionally they'll do that long arm immobilization and follow up. So when you have a broken, displaced proximal ulna, if you draw the line of the radius to see if it intersects with the capitellum, if it's dislocated, think about Montaicious injury. Well, you probably already knew this, right? So let's go on to things that are a little less obvious. And we'll talk about Essex Lopresti injury. So Essex Lopresti injury is a very high energy Foch injury. So it could be a fall from a height, maybe a fall from a motorcycle, snowboarding, something where you've got more than you just fell down going on. So more energy involved. And typically there'll be a radial head fracture, but the radial head will just be smashed as a typical rule. And I'm sure you've seen those once in a while. You go, wow, that's really terrible. And that's a giveaway for Essex Lopresti. Well, what does the rule of the ring say about this smashed radial head? Well, we know that the smashed radial head was shortened, so it was a fracture with displacement. Somewhere in the ulna must be part 2, and part 2 is all the way down at the distal radial ulnar joint again. And here you have the ulna much too long compared to the radius. So that displacement tells you that ligament's been torn, and that's your part 2. So what is happening here is you have the tremendous force applied axially down the radius. You disrupt the DRUJ, then it tears up the interosseous membrane and smashes out through the radius, causing part 2, the shortening. So you have 2 parts and you've broken the ring. In this, in general, elbow symptoms predominate because you've got this nasty fracture, pieces all through the joint fills with blood, and almost always they're going to complain of elbow pain, elbow pain, elbow pain. Now, the clinical exam, though, is important. So when you have someone with a radial head fracture, particularly a bad one, you want to check and see if they got forearm tenderness, because they tore that interosseous membrane, and they'll usually be tender the full length of the forearm, which is not your usual radial head fracture. And they'll also very much have wrist tenderness because the DRUJ was damaged. So you have this unusual combination of a radial head fracture and tenderness all the way up the forearm into the wrist. Here, when you look at the wrist, here's another patient with it, and notice how the radius was shortened and these two don't match anymore. So sort of subtle, but the giveaway is in the physical exam associated with a radial head. Well, things get a little uglier. 75% of these are missed at the first visit, and only 20% of the misses have a good outcome. So it'd be sort of nice if we made the diagnosis so that the orthopedist has a chance for a good outcome, which means the radius has to be operated on to maintain its length. Well, even worse, radial head fractures without displacement are very common, and there are many ELIs that don't have shortening of the radius, but they will have tenderness of the wrist, and they don't have this displacement, so they're very hard to tell. You can imagine they started to do it, they hurt the DRUJ, they started to damage the interosseous, they broke the radial head, but didn't quite have enough force to continue smashing everything to pieces. And in at least one study, they found that 4% of radial head fractures had Essex Lopresti injury. So it's more common than we think. So what do you do when you have a radial head fracture? Well, the first thing to do is to make sure they don't have wrist tenderness. If they've got wrist tenderness, ELI should come to mind, and I think refer them in a way that's a little different than just standard stuff. I think maybe you talk to the orthopod, or maybe send them in with a possibility of more than just a normal radial head fracture. The important thing about these is the surgery is to maintain the length of the radius, and if both ends are damaged, there may be movement later on. So even without displacement, it's possible to get surgery. I guess that's one of those decisions that we'd like to let someone else make. We do long arm immobilization of them and then referral to ortho. So for a high energy Foch injury, not that just I fell down, if they have a shattered radial head, a shortened radius, so then there's part two, forearm tenderness, wrist pain, think about Essex Lopresti injury. Well, let's get a little subtler. What about this? So here we have a child with an obvious fracture of the radius. It's displaced. There's part two somewhere. Where's part two? Now, I will give you a hint in that this articulates nicely. The distal end is okay. So what's wrong with the ulna? And this is a little more difficult. Now, the ulna normally is a flat bone, and it provides sort of the stability whereby the radius can rotate around it and do its thing for supination and pronation. The ulna is sort of the pivot point, and the ulna is flat. But notice in our patient, the ulna isn't flat at all. There's a big bow in it, and that is a plastic deformation fracture. In a plastic deformation fracture, if you imagine a young twig and you press it real hard, and you start it to have little micro fractures, and then you let go, it doesn't go back to straight anymore because it's been damaged on the inside. Not enough to break through the cortex, but enough to damage the interior structures. That's plastic deformation. This can happen. So if you imagine an older tree, you can't bend an older tree and have it not crack through the bark and all. It's got to be a twig. And in the same fashion, This only applies to pliable bones, which means this is only a child thing. And really, it's only a young child thing. A 12-year-old isn't going to have this in general. It's got to be 6, 8, 3, 2 years old, something like that. A child that has a bone that can stretch and bend without breaking. So we're going to take a look at a couple examples of this that I've run across over the years. Here is a fracture with deformity of the radius. And you notice there must be part 2 in the ulna. Where is it? The part 2 is this bow. Here is a fracture of the tibia with deformity and displacement, and notice the huge bow in the fibula. So that's the rule of the rings part 2. So one or both bones of the forearm is possible, usually the ulna, and in the leg it's almost always the fibula. Now, what's the problem with the plastic deformation thing? Well, the problem is there's no fracture hematoma to remodel in the plastic deformation, so that there's no remodeling, so that the bone can't straighten out again. So it has this tendency to want to stay in that position, and that has to be changed. Also, you can't reduce the other bone very easily. Imagine that tibia I showed you with displacement and that big bowed fibula. How are you going to get the tibia out to length? And the answer is that's going to be really hard. And you're going to have to do that, that closed reduction, if possible, under general anesthesia. They often have to break the other bone so that they can get it out to length. And so it becomes a little bit of a mess. So these are a little bit of the orthopedic nightmare for children. Certainly, it's an important discovery because we will have trouble, and general orthopedics will have trouble. We need to refer these often to orthopedic specialists for children. Well, so what's the importance of the rule of the ring? In the forearm and the leg, one bone cannot be displaced without displacing the other. And that's one displacement causes the other. You can't break the ring without doing 2 parts. So let's look at an example. Here we have fracture with dislocation of the proximal ulna. And where is part 2? Part 2 is a dislocation of the radial head. Therefore, the rule of the ring applies. Here we have a fracture of the distal radius. The rule of the ring says there's something wrong with the ulna. What's wrong with the ulna? It is displaced distally because there's a dislocation of the DRUJ. So part 2 present. Here's a Maisonneuve fracture with its destruction of the deltoid ligament, much too wide here as opposed to the rest of the mortise. If you're quick, you can see that the syndesmotic joint's a little wide. Rule of the ring says there must be part 2. It's got to be in the fibula. And by the way, we didn't talk about this because find it because it's going to be way up in the fibula proximately. And that's how it's so easy to miss. It's a classic emergency medicine miss. We know from the displacement of the distal tibia that the proximal fibula, the fibula must be involved. If we can't find it in the ankle, we're going to look more proximally. Well, every rule has its exception, and this rule does not have an exception to the exception. Here is the exception, the nightstick fracture. Nightstick fracture was named for, in days of yore, the police, when they would clear a crowd, would go through them swinging billy clubs at them. And the patient, well, they eventually became patients. The people in the crowd, to protect themselves, would hold their arm up so they didn't get hit in the head. Thus, the ulna was made vulnerable to the swing of the billy club, and it took the brunt of the injury. So this is the place where this is the violation, and that the ulna can be damaged without the radius, and it can even be displaced without the radius being involved, based on this blow to the ulna mechanism. Here is an example of one of the patients I saw. Here's a blow to the ulna with some displacement in the midshaft. Where is the radius part? There isn't. This is classic nightstick. Here is another one. This guy was working on his car. The wrench slipped. He banged into something really hard and has a displaced fracture of his ulna. Where is the radius part? There isn't. It's a direct blow injury. You know, when you look at that, you might say, well, why isn't that Galiazes fracture? Well, two things. One, it's the ulna, so it's the wrong bone. Galiazes is the radius, and the mechanism is all wrong. The Galiazes is a Foch injury, and the nightstick is a direct blow. So it doesn't match. So knowing the mechanism is very important when you talk orthopedics. Treatment for these is long arm immobilization and refer to ortho, sorry. Velociraptor often asks poignant questions. And in this case, it wants to know, is it possible to expect the unexpected? And I think if we get our heads out of the sand, follow the rule of the ring, we'll be able to navigate these subtle orthopedic problems. Thank you for joining.
All right, Dr. Webley, thank you very much. That was fantastic. Let's look at the chat box. Does anyone have any questions for Dr. Webley? You can also go ahead and unmute yourself and turn the video on if you'd like to ask the question yourself. If not, we have a couple. Have some thank yous to Dr. Webley. So Dr. Webley, I do have one question for you while we're waiting for some questions from others. You know, when I've seen this talk a few times and it is absolutely awesome. For some people that don't see these fractures very frequently, what's the best way to remember this? Is it truly just a true repetition every time? Because I feel like it's so clear today, but then when I go to work every now and then, I forget some of the eponyms. What is your advice for keeping people up to date?
I would say don't ever remember the eponyms. That's why the rule of the ring is important. When you find a displaced something in the ulna, there must be something in the radius. So don't bother with the eponym. And it really only applies when it starts to get subtle. I mean, if you have a bad Galiazes fracture and you miss that the ulna's involved, the orthopedist is going to pick that up. It's not going to be a miss. It's when it starts to get more subtle, like Essex Lopresti and or Maisonneuve, that you actually have an issue. So whenever you see movement in the ring, remember that part 2 is somewhere. No one needs to know an eponym. They're completely worthless. It's a shorthand to say, well, Muntasia is a fracture dislocation of the radial head. It's easier to call it Muntasia injury, just from a laziness point of view. But that's the point, is the rule of the ring tells you to look for part 2, and don't bother with the eponyms. They never matter. If you want to sound smart to the orthopedist, great, but otherwise, not important at all.
Those are great points. Another question I had is that you mentioned using long arm splinting for many of these fractures. Are you doing a sugar tongue typically, or like a long arm posterior?
Well, you can do, usually to immobilize anything in the mid shaft of the forearm, you need a long arm, so all the way up. Mm-hmm. If it's very distal, a sugar tongue can be okay. You're never wrong putting a long arm on because it immobilizes. A lot of action in the forearm comes from the elbow, and to immobilize the elbow, you basically have to get the bones that work it, so you have to be up the arm. One thing that's rather important, if you're putting a long arm splint on, so let's see here. So you have it like this, sorry, and you want to be all the way down, but I've seen a child straighten that out in about 30 seconds. Before he got to the car, he had completely straightened it out because I didn't put something sideways to hold it in place. So you have to have some sort of a sideways strut or an AP mold or something to prevent them from straightening it out. So it's just not a slab posteriorly. It's got to have something on the side, or you'll have the same embarrassment I did when they want to know what to do about this. 5 minutes after they left my care, the cast is worthless. So a word to the wise. Can't go wrong with a long arm.
Thank you.
Hey, Dr. Webley, this is Jeff McGowan. Hey, I just had another question as well. I think, I'm sure we have a variety of places that people that work at different locations. Do you have any advice for some of the people that work at smaller shops where maybe you can't really get ortho in-house? Like I said, I know I work at level 1, and I also work at a rural site where, like I said, the likelihood of me getting an orthopedic to come in for some of these complex fractures is almost essentially no, unless it's like a open fracture essentially. Because I think that's kind of where I'm sure a lot of the docs we work at multiple sites. So when I work at my main site, I have ortho residents that come in and they do a lot of this all for us. But do you have any recommendations for some of those that where we can touch base with them or kind of some experience from doing reductions themselves?
In general, I would say there are no orthopedic emergencies. There are vascular emergencies like compartment syndrome and popliteal artery rupture when you have a dislocated knee, but there are virtually no orthopedic emergencies. In fact, a very famous British orthopedist had clinic on Thursday. And it didn't matter what was wrong with you. They would get to you Thursday. So that gives you some concept of how quickly things have to be done. They don't have to be done right away. So almost everything can be simply immobilized and sent on to someone. In general, you would like them to be seen within a week because the bones start to heal in 2 weeks, and you don't want to have them be seen a month later at the orthopod, and what's done is done. So I would say when you have a complicated fracture, talk to the orthopod, make arrangements for follow-up, and then immobilize with long arm something, and it should be more than adequate. The point of a cast is pain relief mostly. In the olden days, they used to have bone setters. Before doctors ever got into bones, there was a guy that would come around, sharpen your knives. There was a guy coming around and would set bones, which meant he made a splint of a kind, and they would just make the patients feel better until it healed. It wasn't until 18th century in France and Italy, which is where you get all these names like Dupuytren and Galiazes and Muntacia and all these names, where doctors even cared about breaks. So yes, what I would say is immobilize, refer in a timely fashion, not a whenever you get around to it. I'd call and say, you need to be seen within a week. We got this guy, when can he come in? I'll put a cast on him and you follow up. I would think in general. That's it. All right, I will move.
Thank you very much.
All right, thank you, Dr. Webley. I always love a great orthopedic review. So we're going to move on to our next speaker, Dr. Charmaine Gregory. I see her video popping on. She is an emergency physician at St. Joseph Mercy Hospital in Ann Arbor and our MCEP 2019 Physician of the Year. She has a particular interest in physician burnout and work-life balance. Dr. Gregory does wellness coaching through her company Fervently Fit with Charmaine, and is a contributing author to the Chronicles of Women in White Coats. You may recognize her from her MMA classes at ACEP. They're lots of fun. Unfortunately, probably not this year, given the virtual ACEP. And her podcast, Fearless Freedom with Dr. G. Please welcome Dr. Gregory to talk about losing touch in the time of COVID. We're also going to have some breakout rooms, so kind of make sure that you're ready for those and flip on your video for those. Dr. Gregory.
Thank you. Thank you. Thank you. Thank you. Thank you so much. I am so excited to give this talk because it has touched me, this experience that we've had over the last few months as we've been dealing with the changes that we've been experiencing as a consequence of the pandemic. So today I'm going to talk about losing touch in a time of COVID. And I have a couple of disclosures. And so just full disclosure, the first one is that I am an avid fan, and I'm not wearing my t-shirt today, so I can't give it a clue, but I'm an avid fan of Star Wars. You probably can tell that from the initial slide because my children are trying, I'm in the middle of a presentation, okay? Thanks. I'm a fan of Star Wars, and you could probably tell that from the initial slide. I also have another disclosure, and that is that I don't have any sponsors. I don't have anybody do I have to actually disclose. But I do have three amazing cherubs, and this particular one absolutely loves to give me critters and shove them in my face when I least expect it. So there you go. So I'm just going to tell you that this talk is going to be interactive. We are going to have trivia questions for those who are Star Wars fans. We are also going to have this talk broken down into 3 episodes. The first episode, we're going to talk about us as the care team, as leaders of the care team. The next episode, we're going to talk about the patient. And then the third episode, we're going to talk about the families of the patients. So let's kick it off with the first trivia question. And here it is. So Baby Yoda, who is absolutely the cutest, and I'm a little partial because I really like Yoda. And he has the first trivia question. And that is, what was Yoda balancing on before Luke's X-Wing sank? Does anybody know what he was balancing on?
Dr. Gregory, this is Dr. Mead. Your view is showing in the presenter view, so it's going to give away your answer.
Oh, okay. How do I fix that? Yeah, it's giving away my answer. I don't want that.
Yeah, I don't think Zoom works well with presenter view. I think you just have to do the.
Well, I think what happened is I clicked the wrong share.
Yeah.
I want to share desktop too. Thank you for telling me that.
There you go.
Is that better?
There we go.
Showing up. Okay, yay, yay. All right. See, thank you for telling me. I appreciate that. All right. So you know the answer. So the answer is his right leg, Luke's right leg. So, now let's talk about episode 1, which is the care team. And we'll kick that off with a little video. And this is going to be before shift, the beginning of a shift. Don't you feel like this is real? I mean, don't you feel like, I know I felt this way. I felt like when we were going into shift at the height of everything, I kind of felt like, man, we're going into something and we only have 2 destroyers. We have 2 X-Wings, and we're going up against this behemoth of a destroyer. And I don't know. I mean, can we really do that? Can we really make a difference? And you kind of feel like you're kind of wading through mud almost because of all of the uncertainties, because of all of the additional stressors that were not present before, and on top of our usual stressors, right? And so it's so important when we think about the care team that we acknowledge the effects that this whole situation has had on the team. Think about the effect it has had on you. think about the effect it has had on the nursing staff, the tech staff, even the environmental services who has to go through and clean those rooms of patients who potentially had COVID or we were ruling out for that. I mean, there is an incredible amount of stress. We're stressed about how can we deliver care when we have little knowledge? We're stressed about how much time should we spend in the room? We're stressed about not being able to get in the room as frequently as we typically can. There's just so many things, so many factors. And, you know, Darth Vader is pretty aware of some of these. And so, you know, he's talking about, you know, the kind of stress that comes with monitoring the time that we are in PPE in the room, because that is not inconsequential. I know for my personal experience, we've had several nurses who literally, you know, they'd go in the room and they'd be in there doing the task that we ordered. And, you know, we had one that actually syncopized within the room. And we had another one that basically came out and was crying at her desk. I mean, so this is not an inconsequential effect. There is a helplessness that we feel when we have previously healthy patients who are dying on us, who are critically ill, and they walked into the door. That is incredibly intense. We have to be aware of the fatigue that we ourselves are feeling, but also the fatigue that our teammates are feeling, and understand when, as a leader of the team, are we gonna be stepping in and having them tap out, take a break, regroup. There is a stress that comes with the detachment from patients that has occurred as a consequence of this particular scenario that we're currently practicing in. We have to also be aware that there is power in our words. When we say things like, oh, you know, very flippant things that may or may not seem that deep at the time, but impact our team. So when we are not positive, when we are very negative in our outlook about the situation, that echoes within our team. That is something that is taken on by our care team. And then we have to also be aware of the micro traumas that lead to PTSD. And so, you know, we normally have this. We have the situation where maybe we may have a bad case. Maybe we might actually have a death that we are dealing with. And we have to go and we have to see the sore throat that's in the next room after we've spent an hour trying to revive a patient and we're unsuccessful. There are so many micro traumas that lead to PTSD, and the pandemic has added additional micro traumas to us as the team taking care of our patients. And so it's super important for us to really be in tune with this. So Yoda had an opportunity to speak to one of our staff. And this is what Yoda, you know, got from them and the feelings that this is what the scenario was. And I'll tell you what that staff member said with the feelings that they had about this. So we had a previously healthy 34-year-old who essentially had an arrest in the emergency department. So this is a healthy person, walked through the door, walked into triage, you know, verbalized their triage, sat down, was placed in a room, probably walked back to their room. They had a pulse ox of 90 on room air. They had complained of a runny nose, cough, malaise, and they had 2 other people in their family who had respiratory symptoms. This person comes back. They're probably in the room for maybe an hour, maybe an hour and a half as their workup is being initiated. And the nurse goes into the room, and then basically the patient is essentially crashing. Totally unexpected. Now, the staff does what they do. We go ahead, we resuscitate the patient. Patient is, you know, we think stabilized, but then they ultimately don't make it. So 34-year-old person who walked into triage, this, you know, the whole team has been taking care of this person, most intimately the nursing staff that's assigned to that particular patient. And now they just had that 34-year-old who is not supposed to die. And that is huge. They're expected to continue to care for other patients who are on their their section, and they're also expected to continue to take care of the next person that comes in with a runny nose, cough, and malaise, and maybe, maybe some hypoxia, maybe not. So Yoda is hearing this person talk about their experience, and Yoda is appreciating how impactful this type of thing is, and how this microtrauma can lead to PTSD, and how this can also lead to rapidly increasing burnout in this individual staff member. So now I would love it if we could do our first breakout session. And here, what we're going to do is we're literally going to focus on one item. So we're going to focus on what kinds of things we can do to essentially take care of the care team. So come up with suggestions about an activity or a tip that we can utilize in our practice that will help us to make sure that we are caring for the care team. It will be 5 minutes in these groups, and the spokesperson, yes, there is going to be a participatory component. The spokesperson will be the person with the shortest hair, and the person who's going to be keeping time is going to be the person with the longest hair. So if we can do that, if you can go into our groups, I know that I think Christy was, okay, there we go. So go ahead and join your groups. Welcome back, everybody. I think we're almost all back, if not all back. Okay, fantastic. All right, so, there were some in the group, I was in group 11, and we had some really great tips for how we can do this, but I would love to hear from some of the other groups. And so let us can we hear from group 2, 4, and 6, please? How about group 2 first? And just unmute yourself, the spokesperson, just unmute yourself and go ahead and share.
I'm unmuted. I don't know whether, can you hear me?
Yes, we can hear you.
This is Dr. Willman, and I can't get didn't seem to be able to get my video. The host is not, okay. You cannot start your video because the host has stopped it. And so,
okay.
There I am.
Yes, we're hearing you.
Thank you.
We can hear you.
Thank you for letting me. Fortunately or unfortunately, I have not been in an emergency department through this COVID stuff, but I appreciate, the feelings that have been expressed, and I, having done this for over 40 years, I can definitely appreciate the difficulties that these scenarios arise. And I don't know any magic words of wisdom to give, but I think that you bringing this up, and making an awareness that, even though we have tremendous stress on ourselves, we've got to realize that we're not alone in this, and that all of the team is relying on you or us, the leaders, to give them support when they need it. And I think we have to particularly make ourselves more aware to the people we work with, that we too are feeling the same thing that they are, but we want to support them in saying, okay, team, this is bad. We've got to get through it. We're doing the best we can. And let's just go on and be the brave people that we are and go forward.
Awesome. Thank you for sharing that. Really appreciate it. Awesome. So is there a spokesperson for group number 4 to share what you brainstormed?
Dr. Gregory, I think there's the slightest chance a couple of us forgot to write down what room we were in.
Oh, okay.
Just
Okay,
to warn you.
that's fair. That's fair. Okay.
Dr. Gregory, I was in group 4. I know I have probably the longest here.
Okay, fair enough.
I can let you know.
All right. Go for it, Dr. Shekel.
Again, yep. We just talked about making sure to debrief, to talk with our staff members, to review these really difficult cases and make sure that we have resources available. Sometimes on a hospital level with really bad cases, they will make counseling services available, and making sure that staff members know if you're hurting, it's okay that we all can, that sharing that they're not the only ones who are hurting can be helpful.
Awesome. That is so important. And so the debriefings that occur, do they occur immediately after the incident, or is there at the end of the shift, or how does that part of it done?
We honestly had a bit of a short time. I think we had some technical glitches within our group, so we never really got there. I think we did briefly talk about both options.
Okay, that's fair. Awesome, thank you for sharing. And then last but not least, group 6.
I think, can you hear me? This is Allison Murphy.
Yes, I can hear you.
Okay. We didn't get very far, admittedly. And honestly, I think I was in group 6, but I don't remember for sure.
Okay, fair enough. It's fine.
So we talked just a bit about different experiences. We had 2 physicians that were not actually working during the pandemic, and then 2 of us that were. I myself work in a very small hospital in Southeast Michigan, and we did not have a lot of cases. So I think really what we brought up was the debriefing idea.
Okay.
I didn't experience a lot of that in my facility. And again, what happened with me was that, I was taking care of patients on the floors and in the ICUs after everybody else had gone home for the night. So I think that ideally we would have done debriefing with the ER team, but honestly, we didn't have a lot of cases that we needed to. So I think, I guess just in general experience though, with other kind of cases, pediatric loss and things like that, I think that it's always been very helpful. So I myself try to do it, but there's no formal organization in our hospital.
Got it. No, that's so important. Thank you for sharing that. And thank you for sharing the perspective of being at a place where you were not inundated with cases, because, that has its own stressors, right? Because now you're like, well, I'm not seeing it. And so what happens if we do get some,
Mm-hmm.
right?
Right.
So no, that's really important. Really important to know.
For sure.
Exactly. Awesome. Thank you so much, everybody, for participating. No, wasn't that awesome? All right. So now we're going to move on to another trivia question. And this time the answer is not going to be up there. So we'll see who the true Star Wars fans are. What did Luke Skywalker promise Yoda as he was leaving Dagobah? My daughter's over here saying she knows the answer, but she's also seen all this stuff. No, you can't answer, honey. I'm sorry. She's disappointed. So Luke promised to return and finish what he began. All right. So now we move on to episode 2, which is essentially the patient. So we talked about the care team in episode 1, and we're going to talk about the patient now in episode 2. And so with the patient, we're going to imagine the patient point of view. This can be difficult. I don't know how many of us have actually been in the shoes of a patient, but it is very different from that perspective than it is from the person taking care of the patient. So what does Darth say? The patient tells him that they're feeling alone. They're feeling helpless because their advocate is not at the bedside like in previous times. They feel like a caged animal with the door closed and, the room being quiet. They're wondering, am I going to die? I keep hearing all these people are dying from this. Am I also going to die? Words are particularly powerful. Words are easily misconstrued when you are laying on a gurney in a room with the door closed and nothing but time to ruminate. Anything you hear, even beyond the door, can definitely have an impact on you. And then they're thinking, man, I wish they would talk to me. They don't come in the room very often. And when they do, the words are few. I wish they would talk to me. So Yoda had an opportunity to talk to a patient, and the patient recounted this to Yoda. I was given a mask at triage, brought back to a room, given a gown, and the door shut. The next person I saw was dressed in an outfit that looked like it was straight out of a sci-fi movie. It was hard to hear. I could not see their faces. I was scared because I don't want to die alone. This is what some of our patients are experiencing. And when we think of our patients, when they come to the emergency department, what do they want when they come? They want a friendly hello. They want to know that we are going to take excellent care of them, because we will. But they also want that human connection that comes from that intimate relationship that's rapidly built in the emergency department between the doctor and the patient. How are we communicating? What are some ways that we communicate? Well, words, by saying hello, by introducing ourselves. We communicate oftentimes through secondary things like whiteboards that allows for the communication to actually extend beyond the time that we're actually in the room. We communicate by our body language, by sitting down, by listening, by leaning forward, engaging, interest, showing interest. We also communicate with our face, with our smiles. And now, during this time, this is what my introduction looks like when I enter the room. I'm saying, hello, I'm Dr. Gregory, but you look and you see the goggles, the head cover, 2 masks. If they saw me in the grocery store, they would not even know who I was. And then my typical introduction is also accompanied by a smile, by a wink, perhaps. Can they see any of that? Can they tell that I'm smiling beyond the mask? They see this person come in the room and they say, hi, I am Dr. Gregory. Then, thankfully, there is a name badge that is displayed high up on her uniform that at least has a photo that I can relate to. As she's talking to me, as she's telling me all that she needs to tell me about my care, I have to focus on that picture and the name because guess what? I cannot see her face. I cannot see her smile. I cannot see her expression. The patient experience is very different in these days, and it is definitely very imperative for us to think about how that experience has changed and how we can make it better, effective, and powerful for our patients. Why? Because that is going to give us the most amount of data as we work in a paucity of data environment that is high stakes, high risk. If we have patients who trust us, who have built rapport with us, who are willing to tell us and spill the tea, we can take much better care of them. So this time in our breakout groups, 5 minutes again, we will be focusing on what is working to make patients more comfortable. All right, I'll see you on the other side.
Okay, I hope I get put back in the right room.
Okay.
Oh, all rooms are the right rooms.
Absolutely, absolutely.
Okay.
All right, Maddie, do you want to drop us into breakouts?
Yes, sorry, currently splitting them up.
Okay.
All right, we are coming back. Yay. All right, can we hear from group 1?
I am a group 1. I'm Jeff McGowan. How's it
Fantastic.
going, everybody?
Yay.
I believe I have the shortest hair out of all the group, so I'll take that. Our overall group, we kind of all talked about that. All of us we all acknowledge that there's changes, but we haven't had any. I mean, I know our hospital system as well as our like ER group hasn't had like a formal way of like how we're supposed to really kind of discuss the changes and how that affects the patients. I mean, I think each of us kind of have been taking our own individual way of kind of like acknowledging those things, because I feel like, you know, a lot of our elderly patients and things like that, a lot of us talked about like, you know, they're very isolated to begin with, and then you even isolate them even more in scenarios like this, and just acknowledging that we understand that there's struggles from that standpoint. And I think when you talked about having breakout sessions and stuff, I think one of the challenges is that, I know for me, time is a big issue. You know, if you're working in a smaller, like I work in a rural site, which makes it a little bit easier because you know your team really well. But I also work at a big site, and we've had a lot of big nursing turnover. And the other people in our group said the same, that we've had, like I said, 40 or 50% turnover in just the last like 2 years or so, just in general. Okay. And so, like I said, even when I'm working shifts, I've been working at the same since I was a resident for the last 8 years. But I mean, I see new nurses and new techs. I feel like almost every shift or every other shift that I haven't met before. So it is hard to kind of get that cohesive, like, hey, like if we have something to debrief, because I said experienced nurses and experienced docs, we all kind of see things and we've all experienced them all together. But when you have a lot of new people, it is hard to know like what their own feeling is about a lot of things. So it's kind of hard to, and then with the residents and stuff too, a lot of times it's just busy. I mean, I know our numbers at our hospital are getting much closer to where we used to be from pre-pandemic. So I know our busyness is definitely kind of picking back up again. So.
Okay, all right. Thank you for sharing. Group 3. What are some things that we can do to make the patient experience better?
Well, I think some of the things we talked about were not ignoring some of the abnormalities that they're experiencing right now and alleviating their fears. Addressing the issues such as the masks and their inability to read our facial expressions, and trying to be more verbal with them and more in tune to their fears, individualize the encounter, update them more frequently, and just stay in tune to how they're experiencing their hospital stay.
Awesome, those are great. I have a question on exploring the update situation. Are there any mechanisms through which that's being done? Is it a open the door and quickly tell what's happening and then close the door, or is it something different? Does it look different?
Well, I can tell you at my hospital, I work at a fairly busy, larger facility, and it varies depending on our current volume, and it also, I've seen, vary depending on the physician. I try to make it as personal as possible, try to actually enter the room and speak to them, and not make it a fear-like situation for them where I'm afraid to actually encounter them. I know a lot of physicians will use the phone system and call them. We use mobile heartbeat at our facility, and that allows us to actually call the patient room and talk to them and update them.
Yeah.
One of the advantages of that actually is that it makes those encounters and touching base with the patient more frequent, which is nice.
That is nice. That is nice. Okay, great. Thank you for sharing that. That's very helpful. Group 5, what were some of the things that you came up with that will help to make the patient be more comfortable during this time?
So we actually had one provider who was fortunate or unfortunate enough to have contracted and then recovered from COVID this spring. So he's actually able to take his mask off and talk to patients, reassuring them that he's safe from transmission. For the rest of us that are still mortal, we still go back to the basics. We still sit down with the patients and have talk with them. We find ways to show that we're smiling from behind the mask. The one provider said she is practicing smiling with her eyes to maintain that human connection. So, we still just go back to the basics, even though there's the physical barriers of maintaining that human connection with them.
Fantastic. Fantastic. Thank you. I love that. Smiling with your eyes. That's fantastic. Thank you for sharing. And so, one of the things that we mentioned, so smiling with your eyes, having a photo somewhere. So I showed you, my ID badge, but there were some team members at Scripps Mercy Hospital in San Diego that basically took it a little bit of a step further, and they actually put their photo and their designation on the front, like they made a pocket on their gowns, so that each time when they went in the room, the patient would then be able to see them very clearly without mask and without goggles and shield and whatnot. But these are some really good examples of how we can do this. Articulating that we're smiling, saying that verbally, smiling with our eyes. Sitting down and doing the things that we typically would do previous to this, despite the barriers. Even the one suggestion that came up also was utilizing your phone, but having a photo of yourself on your phone. So a lot of people do put their phones in plastic bags or some kind of sealant, so that's easy to be decontaminated, and you can take it into the room with you. So having a photo of yourself on your phone is an electronic way in which you can show the patient a bigger version of you, so that they can feel more comforted. So all of these are fantastic. So Baby Yoda is back, and Baby Yoda has another trivia question for you. And it is, what did Yoda tell Luke Skywalker about his weapons when Luke was going into the cave on Dagobah? He said to Luke, "Your weapons, you will not need them. All you need is you," basically, is what he's telling him. And so episode 3 is going to be the family. And so for us, our job as the leader of the team is to think about how we can mitigate family disruptions during this time. And Darth provides us with some insight. They're feeling like they're missing information, like there's a gap. They're feeling helpless because their loved one is suffering alone. They also feel like they're not able to be the advocate for their loved one that they typically are able to be. They're not at the bedside. They're also waiting patiently, either out in the car, which it seems like a lot of my patients' families do, is they sit out in the car waiting for the phone call. So they're at home and they're waiting for those updates by phone. They are also appreciating that words are very powerful. So, the words that we share when we do talk to them mean so very much. They mean so much more than when we are literally talking to them at the bedside and they're seeing us multiple times and having multiple encounters with us. Those words are extremely powerful. So we definitely have to be aware and choose wisely the ones that we use. So Yoda had an opportunity to speak with a family member, and this is what she told him. "I felt guilty, but happy at the same time. My dad fell and was brought to the ED from the nursing home. I had not seen him up close or even got a chance to touch his hand in so long. I have waved at him through glass and imagined what it would be like to give him a hug again. I'm glad that he was not hurt and grateful for the opportunity to see and touch my dad again." So the impact on families is definitely not inconsequential. The patient feels it, we feel it, but the families are also feeling it. So for our last breakout session, we're going to talk about how we can work on keeping the family engaged. Thank you for sharing. That was amazing. All right, as we come back, the groups that are going to be on the hot seat are going to be 7, 8, and 9. So is there a representative from 7 who is up for sharing what kinds of things you're utilizing or that your group came up with as far as engaging the family?
I can't remember what group I was in, but
Okay, well, go ahead and share, no problem.
but I can say that well, currently I'm not practicing during COVID, which, you know, I feel for you guys in all respects. But at the same time, I thought that, you know, and our group thought that this would be possibly a good way to do it, is to have a good line of communication between the patient and the family, and then relaying messages of actually what they're saying to each other as well, and things like that. So there's open communication, and then also have a lead family person contact for, you know, and then they could talk to the rest of the family about it. And then, you know, we didn't know for sure as far as there's such variation in physician as far as what they do normally, as far as before COVID, as far as talking to patients and not talking to patients, and, you know, trying to get them to be more aware of, since the patients can't come into a consult room, and, or I mean, the family can't come into a consult room to talk to, and they'll be in the car or whatever, that in this situation is more important to have communication back and forth, and then actually to hear from the physician, if possible, or the nurse can relay that the physician said this about the patient, and the patient's doing okay right now, and stuff like that.
Excellent. Thank you for sharing that. Group 8, do you have insight to share?
There was nobody that got on in group 8. That was an empty one.
All right, no worries. What about group 9?
Well, since nobody's coming on, I believe I was in group 9.
Okay, fair enough.
You know, we had talked about better communication with the family, using ways as far as electronic, you know, maybe iPads with the family and the patient. Better communication between the doctors and nursing staff, as far as with the family, to help them understand the basics of where everything was standing and what kind of, I think especially with symptoms, what to expect, how bad everything is, and just being upfront with people, people's families. You know, I was not able to work during the COVID time, but my brother went into the hospital March 30th of this year, and
Okay.
bilateral pneumonia. We were unable to see him. Nobody, you know, my family was frustrated because there wasn't any basic contact. He ended up dying April 11th.
Oh, no.
And, you know, I fortunately, I was able, after not knowing he was even in the hospital, my mother contacted me and told me what was going on. And I was able to call and discuss with doctors and nurses, and then relate back to my mom and sister what was happening. And, you know, I don't know if I hadn't been present, or I had been a lay person, whether that would have, you know, even been any situation, you know, that they understood what was going on. We certainly couldn't get in to see him. And it wasn't until his last, you know, when the last 24 hours came along, that we were actually able to go into the hospice room at a nursing home that,
Wow.
you know, and so there's so many electronics out there somehow, you know, the hospital, you know, can, for older generation, people that don't understand electronics and or have them themselves, you know, to be able to use that for communication, and then verbal on the telephone to keep the family in the loop so they understand and everything, you know, where the course of events is going. That was my insight.
Absolutely. Thank you for sharing that. I mean, that's a very personal story. I really appreciate you being vulnerable and sharing that with us. It definitely gives us a very vivid image of the experience from the family standpoint, which, you know, we may or may not have experienced. So I definitely appreciate you being open about that.
It was difficult. I lived in an entirely different city, and, you know, that my brother was admitted through, and you know, I think it would have been horrible if nobody had communicated sooner with, you know, with my mom and sister. That's the only family he had.
Wow.
And, you know, we were able to talk through the telephone, but he was in and out of consciousness, you know, and his, he was altered, and several times that I talked to him, you know, wasn't very coherent, but, you know, it was difficult for them.
Got it. Got it. Thanks again for sharing.
You're welcome. Thank you for your compassion and encouragement. And, you know, there's so many people that need it.
Absolutely. Absolutely. You know, this is a heavy talk. This is a heavy talk. This is a talk that, you know, we don't always think about the impact that the situation that we're currently in is having on us, those around us, those that we serve, those that are caring for and about those that we serve. And so it's so imperative for us to really be thinking about the different elements. So acknowledging the effects of this scenario on the care team, imagining the point of view of the patient, and then doing our very best to mitigate family disruptions, because that's really, that whole cycle is really the only way in which we're going to be able to get ourselves through this, be able to get our patients through this, and to be able to get our patients' family through this. So I appreciate you for your participation, for your sharing, for your time, for listening, for participating. And most of all, throughout all of this, I hope that the force is going to be with you. Thank you.
Thank you, Dr. Gregory. That was great. Thanks for getting us all involved and everything like that as well. Do we have any questions for her? If you have questions or anything like that or comments, you can unmute yourself. And then I said, if you want to throw your video up as well, that would be fine.
Thank you, Dr. Gregory. It was that was a great presentation. I love the sharing of everybody and the knowledge.
Thank you for participating, Kathleen.
Yeah, I have a question for you, Dr. Gregory. This is Jennifer. I would love advice that you have regarding the debriefing process after a traumatic case in the departments. I know we talked about this in our breakout groups. I would love to know from you, like, how you approach this, because I feel like it's something that I've talked about many times through the years, but have never found a process that really sticks. And I think that it's really absolutely crucial for longevity and mental health.
Absolutely. Now, I could tell you that there has been quite a bit of work done on this, and you can literally do effective debriefing in about 10 minutes. And oftentimes we think that it takes a long time. The longest period of time that it actually takes is gathering everybody on the staff. So you have a critical case that has happened. There's been a bad outcome or there's been a death, and you need to gather everybody in the room. And then the first question that you ask is, how is everybody doing? Or you can start with, is there anything that you would like to have done or gone differently than that happened? And then you get maybe one or two answers. And then you say, well, how can we be better in the future? So you always want to acknowledge everybody's feelings, and you allow for a few answers. And usually that only takes a few minutes. And then you want to say, well, what could we have done differently? Or how do you think that went? Oftentimes people will say that even if there's a bad outcome or the patient died, they will say, oh my gosh, we put everything into that. There's nothing else I think we could have done differently. But it's just the thought of speaking about it that makes all the difference. And so, those things, allowing for emotions to be aired, allowing for suggestions to be made, and then acknowledging the hard work and effort that everybody in the team put forward. And if it's a situation where the debriefing is happening in the room where the patient is, so for example, if the patient just died, like before the debriefing even, the most immediate thing that can be done is once the patient has been called, like, so you say, you ask anything else, any suggestions, and they say no. And then you say, okay, time of death is X time. The next thing that you should say, or you can say, and it's very powerful and very effective, is at this time, we would like to take 30 seconds to acknowledge the life of this, and then the person's name. Because that is huge. Because oftentimes what happens for us is that we're like disappointed. We're like, oh my God, we failed this person. We have not done our job as physicians because we have not saved this life. And sometimes the life is just not able to be saved. Sometimes it's just inevitable that this is what's going to happen. But you have to acknowledge that that person has a backstory. Acknowledge that that person, even if it is a child, that child still has a backstory. That child still has people that care about it, him or her. And so just acknowledging the precious value of that life can make a huge difference for everybody in the team. And then when you do the debriefing, like I said, 10 minutes, but you always have to have a extension. So you have to have a way for them to, if they want to do more deep work, that they have somewhere that they can go. So, you can even have let's maybe have like a checklist. And on the checklist, how is everybody doing? How did that go? Is there anything we could do differently? Great job. If you want to speak more, here is the contact information. It is confidential. Because that is huge. Because those microtraumas are very, very, very sneaky, and they build up, and you think you're okay. You put your trauma in your little box, your compartment where you think everything's all good, and then you move on, and before you know it, you're like, I hate medicine. I don't want to do this again. And it's not because you hate medicine. It's because you've had so many microtraumas and you've never dealt with them.
Thank you so much. I appreciate that. That's wonderful advice. Thank you.
I agree, Dr. Gregory. I think it kind of finalizes just taking those few seconds or a minute to acknowledge the deceased. And, maybe even with a lot of people that have had this trauma, they can resolve, their feelings.
Absolutely.
Yeah, just to go along with that as well. I said, I like, we usually do like a little talk at the end. I work with residents as well. And I usually kind of do a quick synopsis of the case before we do anything else that we want to do. I just kind of do a quick run through, like, hey, we had the patient came in asystole. We don't have any other history. We did this, 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 and this, and this. And then I kind of say, is there anything else that we can do? So that way people feel like we kind of did like a full, kind of like from the start to finish of what we know. Was there anything else that people kind of thought of or could do as well? So that way people feel like we kind of went the whole gamut. We kind of talked about everything about the case that we know at least. And sometimes I feel like that helps. But yeah, I feel like it is hard, especially when it's busy, to really get those, 10 minutes, 5 minutes or something like that. Because I said, a lot of us that work in those big centers, like I said, it's like level 1, level 2, level 1. It is hard to bounce around. So it is hard. I feel like the hardest thing is to try to get all the bodies, like get everybody back to wherever you need to have them. That's definitely a challenge, I know, at our hospital, as well as I'm sure many.
I agree.
Any other last minute questions?
I was going to say, I found it's helpful to kind of go through the case too, like before we call the code and say, look, this is what we've done. Anybody in the room have any other thoughts? Like, and that kind of involves them kind of in the care if you've been making those decisions along the way. And I think that kind of is helpful kind of to recap the things that you've done. And then like, was anybody thinking of anything different? Did you get a different piece of information that I didn't hear? And I think that kind of wraps things up too for people.
Absolutely, no, those are great points. The real-time effects of it are huge.
All right. Well, thank you, Dr. Gregory. That was an excellent talk. Thank you for splitting us up and everything like that, and get everybody involved as well. Trying to change up our way that we do all of our summer series and keep it fresh for everybody. So thank you very much. All right. Next, we're going to introduce our next speaker, which is Dr. Nick Bucky. He's got 2 different topics back to back today. Both are about 15 minutes or so. Dr. Nick Bucky is a residency program director at McLaren, Oakland, and Pontiac. He's also associate professor of EM at Michigan State University College of Osteopathic Medicine. He's done a number of talks with us in the past, and he's going to start with "The Pen is Mightier: Updates on Priapism Management," followed by the Michigan Strangulation Law.
Well, thanks, Jeff. Good morning, everybody. Thanks for inviting me to speak. Give me a minute while I get all my screens shared. All right. Screen 1. Okay. Everybody should be viewing a PowerPoint presentation. And can I get a thumbs up to someone to make sure that I got my PowerPoint presentation? Awesome. Yep. So good morning, everybody. Thanks for inviting me. So like Jeff said, I'm Nick Bucky. I am a residency program director at McLaren, Oakland, and I'm associate professor at Michigan State University. Given this topic on updates in priapism management, we were had a very unique position a couple years ago where we had a single patient who presented multiple times to our emergency department with acute ischemic priapism. Each time he presented, he vehemently refused any surgery. The first couple times he presented, the urologist came in and offered him the definitive surgery, which is some shunting procedure, and he vehemently refused the surgery. He just appreciated the emergency department management and would only want us to treat him in the emergency department. The last time I saw him was his 28th visit for the same condition, and I know he presented multiple times after that over a several-month period. So it worked out pretty well because during that time we did a lot of dives into the literature about the best management. We did a lot of discussions on the best practice management for him. We were able to trial different techniques because there are multiple different techniques I'll talk about today in the treatment. And we were each provider was able to figure out which technique we liked the best. So we quickly became a one-patient center of excellence for the management of acute ischemic priapism. With that, I kind of designed this presentation more as information for our residents, so we could stay briefed on the updates. But when Jeff and Therese heard that I had this presentation, they thought it would be good for this group and asked if I would be presenting it, if I'd be willing to present it. Of course, I said yes. So conflicts of interest, short story, I have none. I get my clinical salary from American Physician Partners, a big national group. I do get a salary from Michigan State for my service as an associate program director and from McLaren, Oakland for my service as a program director. Both of these two have scholarly activity obligations where I'm expected to do external lectures such as this. But in terms of commercial products or services I'm going to be promoting, there are none. I have none. So let's talk about what we're going to talk about today. By the end of this presentation, an emergency physician will be able to describe the anatomy and physiological processes causing the priapism, We'll identify the anatomic landmarks to perform a penile nerve block. We'll be able to identify structures to avoid when providing a penile nerve block and in treatment of a priapism, and then describe 3 different techniques to accomplish detumescence. So let's talk about how priapisms work. And this is how the penis works. So what we have is we got the 2 corpora cavernosa. These are spongy tissues, and in the middle is the cavernosal artery. Each corpora cavernosa is surrounded by a fibrous layer. And then on the outside of the penis, there's another fibrous layer. And between the corpora cavernosa and the tunica albuginea, the outside fibrous layer, is this venous plexus. So in its flaccid state, you have got this constant supply of blood through the cavernosal artery into the corpora cavernosa. And you have an equal amount of drainage through the venous plexus because this space is open. So in the flaccid state, there's this continuous flow of blood in and out of the penis. Now, if you notice the corpora spongiosum, which is continuous with the glands, is a separate compartment. The 2 compartments of the corpora cavernosa are in communication with each other. So they're not unique separated compartments, but they are actually 2 compartments with a continuous communication of blood. What happens during the erect state, so during sexual stimulation, is you get this increased flow of blood into the corpora cavernosa, and that increases the amount of blood into this spongy tissue inside the corpora cavernosa. And not only is there increased flow, but as the corpora cavernosa engorges, it compresses the venous plexus, the outflow tract, between the tunica albuginea and the corpora cavernosa, which further creates engorgement of the corpora cavernosa, and that's how we sustain and maintain erections. Then what happens is when the sexual stimulation ends, either through after ejaculation or there's an end in the sexual stimulation, there's this multifactorial process. And of course, multifactorial is Latin for we don't know the exact mechanism, but there's a multifactorial process in which case there's a decrease in the arterial inflow of blood, which causes just a slight bit of decompression of the corpora cavernosa, which opens up this venous plexus, which causes rapid outflow of the blood and rapid detumescence. So what happens in priapism is either after sexual stimulation ends or if there's engorgement of corpora cavernosa without sexual stimulation, you get engorgement of the corpora cavernosa. You have this increased arterial flow, you get engorgement, you have compression of the outflow tract, but then that doesn't go away. And for whatever reason, that multifactorial process where the corpora cavernosa decompresses a little bit and opens up these venous tracts doesn't occur, and then you have the sustained, maintained erection. Now, these only occur within acute ischemic Prypism with the corpora cavernosa. The corpora spongiosum is a separate compartment. So that's one way you can determine, differentiate between a penis that's erect through sexual stimulation versus an ischemic Prypism, is that in a Prypism, the corpora spongiosum and the glans penis are not engorged. So those remain flaccid while the 2 corpora cavernosa remain engorged. So what happens in this process, by definition, a ischemic Prypism is the engorgement of these corpora cavernosa for more than 3 hours. And what happens during those 3 hours is eventually the pressure in the corpora cavernosa exceed the pressure of the arterial inflow. So you stop getting engorgement of or continued engorgement of the corpora cavernosa, but that blood becomes stagnant. And when blood becomes stagnant, it becomes hypoxic. And when it becomes hypoxic, it starts causing necrosis of the surrounding tissues. Also, as that blood becomes stagnant, it starts becoming acidotic. And the acidosis also starts causing damage to the surrounding tissues. And that's another way you differentiate a Prypism, because Prypisms are painful. Erections are not painful. Prypisms are painful, and they're painful because after about 3 hours, you get this ischemic or hypoxic and acidotic blood causing structures to the causing damage to the structures. And these structures where there's a lot of moving parts in the workings, in the normal workings of the penis, once they start getting damaged and corroded from this acidotic and hypoxic blood, is when we start having serious bad outcomes, mostly erectile dysfunction. Which is why it's always recommended when you have a patient with ischemic Prypism, you always consult your urologist. Even if it's in our case where the urologist says, yes, I agree with your plan, go ahead and manage it yourself. You always want to call a urologist and get them on board, because even when these are treated appropriately, there's often bad outcomes. In fact, usually there's bad outcomes in terms of deformities because of the treatment we provide, or because of, or in terms of future erectile dysfunction. So because there's usually bad outcomes with these, you always want to get the specialists on board, even if they agreed to let you manage it in the emergency department. So So ischemic prypism, you have engorgement and stagnation of this blood in the two corpora cavernosa. So there's two other types of priapism. One is the non-ischemic or high flow priapism. What I just described is the ischemic or low flow priapism. Low flow because once the blood is in there, it becomes stagnant and stops flowing, and then it becomes ischemic. The high flow or non-ischemic priapism is a rupture of this cavernosal artery. So usually it's due to a trauma. So there's during sexual intercourse, there's some vector force that's not normal, and it ruptures this artery. And when this artery ruptures, you in essence get a intracavernosal arterial bleed into the corpora cavernosa. Now what happens is usually because that's a traumatic event, the sexual stimulation abruptly ends, and then you get detumescence of the corpora cavernosa, except in the area it's bleeding. So you have this one area of focal bleeding that causes swelling in the area, but because the rest of these venous plexuses are open, you get rapid drainage. So it's usually pretty easy to differentiate between the high flow non-ischemic priapism and the low flow ischemic priapism. The textbooks say you can do things like blood gases because in a high flow or non-ischemic, you'll have arterial blood, high oxygen, low CO2, normal pH. Whereas in the ischemic or low flow priapism, you'll have the hypoxic, acidotic, high levels of CO2 blood. You can do that. It's really not difficult to differentiate between the two. The high flow or non-ischemic, they're not really emergent because there's the rapid inflow, there's the rapid outflow of blood. The blood is not ischemic. So those really are not emergencies. In fact, they're appropriate for outpatient follow-up. Most of the time when I've seen those, the urologist does come in because they're so disconcerting to the patient that sending them home with outflow or with outpatient follow-up is not well received by the patient, but they're technically not emergencies. The only emergent condition is the ischemic low flow priapism. The third type is what they call stuttering priapism, which is this recurrent non-sexual stimulation engorgement of the corpora cavernosa, but they'll go away after 3 hours. So they'll engorge and then they'll disengorge. They'll engorge and they'll disengorge, and they don't get hypoxic or ischemic. These we rarely see because they usually just follow up with their primary care doctor or urologist. If they do have these stuttering priapisms that last for more than 3 hours and they start becoming painful because the blood is now hypoxic and acidotic, they present to the ER and they're treated just like an acute ischemic priapism anyway. So that's how priapisms work. What we're going to talk about now is how to treat them. So the first thing we want to do is anesthetize the area. Remember, these are painful. Because they've been hypoxic and acidotic and there's ongoing damage to the very sensitive tissues, they're painful conditions, and the treatment we're about to do are exquisitely painful. So we want to anesthetize the area. Okay. Two different techniques in this area. One is a ring or is either a ring or a field block. And what you do is you create 3 wheels anesthesia, and you do this actually on the abdominal wall, right where the penis protrudes from the abdomen. And once you have these 3 wheels, then you inject in a ring type pattern all around the penis, and that will bathe the whole area, including the penile nerves, and that will anesthetize the penis. The other technique is to do a direct injection. It's a blind injection, but you can actually go at about the 1 o'clock and 11 o'clock position. You want to inject, use a small gauge. You can use a very small gauge needle and inject just as you pass through the tunica albuginea. You can, because it's such a fibrous tissue, you can feel an actual palpable pop as you go through, change in pressure as you go through the tunica albuginea. You'll notice the arteries are right next to the nerves. So what you want to do is aspirate, make sure you're not doing an intraarterial injection, and then you inject about 1 or 2 milliliters of a local anesthetic in the area. I prefer, we had much better success with this technique. The ring block or a regional block, it's difficult. There's a lot of you're doing this on the abdominal wall. There's a lot of redundant tissue. There's a lot of hair in the area. So it's really hard to do this procedure. We had a lot better technique with the direct anesthesia. There are, the latest textbooks are saying there are uses for ultrasound. They advocate for, or at least offer, ultrasound guided penile nerve blocks. In the literature review I did for this, I couldn't find any literature about ultrasound guided penile nerve blocks. I looked at the references the textbooks actually cited, and none of them were actually talked about, none of the studies that the textbook cited talked about ultrasound guided penile nerve blocks for priapism. All the studies they cited were in newborns doing ultrasound guided penile nerve blocks before circumcision. So technically there aren't any studies studying ultrasound guided penile nerve blocks, but as someone who does a lot of ultrasound guided nerve blocks now, I can't imagine it's very much different than doing a nerve block anywhere else in the body. The caveat when you're doing this injection, you want to do it as proximal as you possibly can to the abdominal wall where the penis protrudes from the abdominal wall, because these nerves start branching really quick. And if you do it too distally, you might not get a branch of the nerve and not get complete anesthesia. So step one is to anesthetize the area. The technique we had the most success with was direct injection at the 1 or 2, at the 11 o'clock or 1 o'clock position, aspirate, make sure not intra-arterial, bathe the nerve in a couple cc's of local anesthetic, and then you get good anesthesia. Once you have anesthesia of the area, you want to, the goal is to get detumescence of these corpora cavernosa. And remember, the goal is to open up these, the normal venous system. So what you want to do is get enough decompression of the corpora cavernosa, just enough to open up these venous systems so you can get the natural outflow of the blood. So step one you want to do, and it's also worth noting that you only have to do this unilaterally. The two corpora cavernosa are in communication with each other. So if you decompress one, both will decompress. So you don't need to do this bilaterally. You can do it from one side. So step one to achieve detumescence, to decompress the corpora cavernosa, is simple aspiration. Put an 18 gauge needle into the corpora cavernosa, hook up a syringe and start aspirating. You can also hook up a syringe, I'm sorry, I forgot to mention, you definitely want to avoid the dorsal and ventral parts of the penis. The dorsal part is the neurovascular bundle, and then ventral you've got your corpora spongiosum and urethra. You definitely want to avoid these areas because they're already going to have enough bad outcomes from particularly erectile dysfunction in the future. You don't want to mess with your ability to urinate also. So when you're doing these procedures, you want to inject exactly at the 9 and 3 positions. When you do those, you're avoiding all these dangerous structures. So aspirating, you put a 18 gauge butterfly directly into the corpora spongiosum. You can aspirate. You can also just hook the tubing up to a basin and let it drain there. The advantage to this procedure is it's a single injection, a single poke into the corpora cavernosa. So remember, these are very fibrous layers. They're not intended to be cut, and they're not intended to heal very well. So when you remove the needle, there's a lot of hematoma formation because they don't seal up very well. And then there's a lot of deformities as they scar. So if they don't have future erectile dysfunction, if they are able to achieve erections in the future, often they have deformities and crooked erections. So we really want to compromise this tunica albuginea as infrequently as possible. So what we do is we inject the 18 gauge needle, and then you can actually help aspiration by milking the corpora cavernosa, toothpaste-like, squeezing the blood into the needle and letting this drainage. The textbooks say about 5 cc's of drainage is all you need to remove 5 cc's of blood to create enough decompression of the corpora cavernosa to open up these venous outflow to allow natural detumescence. In my experience, that has not been enough. We've removed far more than 5 cc's and still didn't achieve appropriate detumescence. So the advantage of this technique, like I said, is a single injection. The disadvantage of the technique is it really doesn't work. In our experience, it just didn't work very well for a couple of reasons. First of all, you're injecting the needle into the spongy tissue. It's not a contained area of blood. It's a spongy tissue. So I liken it to trying to aspirate water out of a wet sponge using a needle. You just don't get a lot of active drainage. And this blood has been sitting around for about 3 hours. So it's thick and it's congealed and it just doesn't aspirate very well. So while this is a technique that is offered and is available, in our experience, it really didn't work very well. So direct aspiration is one technique. The next technique is irrigation with aspiration. So this is exactly the same. You inject a needle into the corpora cavernosa, a big 18 gauge needle. You attempt to aspirate, but then you put another needle, a butterfly, same large bore, 18 gauge, more proximal, and you start flushing with saline. And the whole point is to flush and get this blood moving and aspirate more blood than you inject fluid. And by getting this flow going and aspirating more blood than you inject fluid, you'll create decompression of the corpora cavernosa, open up these veins, and allow detumescence to occur. This was another technique we used with varying degrees of success. The third technique to use, you've got simple aspiration, and you've got irrigation with aspiration. The third technique is injection of sympathomimetics or vasoconstrictors into the corpora cavernosa. I should have on the slide removed this needle because it's not an aspiration technique. You just simply inject some sort of vasoconstrictors into the corpora cavernosa. For whatever reasons, and there's not a lot of literature on this, phenylephrine has emerged as the preferred vasoconstrictor. The recommended dose is 200 micrograms. And if you can see, the dose of the phenylephrine comes in 50 milligrams for 5 milliliters, so you have to do your own dilutions. I always recommend looking it up. This is just not a procedure we do very often, so I wouldn't recommend memorizing the doses if and when you have to do this procedure. Just look it up and do the math again at that point. So what you do is you simply inject 200 micrograms directly in the corpora cavernosa. Now I know it makes a lot of us cringe because we've all been told the dogma of you never inject vasoconstricting agents into a terminal digit, the fingers, toes, penises, or nose. But really what we're doing here is we're not directly injecting it into any of the vascular structure, or into the arterial structure. We're injecting it into this big corpora spongy cavernosa. And the intent is then, very quickly, this will cause enough local vasoconstriction to open up these veins, and all this phenylephrine will then not go into the distal part of the penis, but instead drain back systemically and be diluted systemically. So the dangers of injecting into a terminal digit are not there. So you inject 200 micrograms, you can repeat that every couple of minutes. What we found to have success is you inject the 200 micrograms and you actually apply manual compression, and that diffuses the phenylephrine into the local area of the corpora cavernosa, which causes vasoconstriction of the corpora cavernosa, which opens up these arteries and allows flow. So those are the three techniques to use after you anesthetize the penis. You can either do direct aspiration, you can do aspiration with irrigation, or you can do injection of a vasoconstricting agent, and phenylephrine has become the preferred choice. So that's my quick talk on priapism. What I want to do now is talk about the literature review. There's a couple literature updates, which really there are none. There is very, very little literature at all in terms of management of priapism. All of these recommendations are consensus statements by urologists. All of the recent literature I did in my literature review are all review articles telling exactly what I just told you now, and everyone's citing the exact same literature, which is consensus statements. There were a bunch of case reports. I'm sorry, the only actual study I could find was a retrospective review from one institution, and really they found out that phenylephrine was the preferred injection. It wasn't a case controlled. There aren't any case controlled studies. The only actual study out there that I could find was a retrospective review promoting the use of phenylephrine as the vasoconstrictive agent. There were a lot of case reports, a couple case reports that I thought were interesting of mentioning. This one from the Iran Journal of Public Health from just a couple of years ago, 2017, they applied leeches to the area. They considered that a successful intervention, even though 2 days later the patient still had a priapism. So I questioned their results and their techniques. For us, I know we don't have leeches in our Omnicell anymore, so we can't use that in our department, but I thought that was a fun case report to present. The only other one that I thought was relevant for us was this one, where a slightly after injection of the corpora cavernosa with phenylephrine, the patient went into a hypertensive crisis, and the priapism resolved successfully, but the patient went into a hypertensive crisis, went into cardiogenic shock, went into flash pulmonary edema, needed intubation, and had needed inotropic cardiac support for multiple days until you regained cardiac function. Turns out that patient had been taking huge doses of pseudoephedrine himself, trying to relieve the priapism himself before coming to the emergency department. So the pseudoephedrine that he had taken orally combined with the phenylephrine put him into a hypertensive crisis. So it might behoove us to ask if the patient has tried anything themselves before injecting phenylephrine. But that is my presentation on the management of acute priapism and current literature updates. Do we have any questions?
So we were all in the background comparing how many of these procedures we've each performed. Last I saw, Dr. Stevenson, I think, was the winner.
Yes, she is.
With 3 to 4, or maybe more than that. I don't know, there are quite a few. I had one question. What is your preferred anesthetic for the nerve block you described?
Yeah, that's a good question. I just use lidocaine. I really don't, you know, the bupivacaine, the long-acting local anesthetics, I don't know why they concern me in this. I guess I really shouldn't. But usually once you get the detumescence, the pain goes away. So lidocaine has enough, you know, lasts long enough for us to do the procedures we need to do.
Thank you.
Nick, how do you know that you're not in the artery before you're injecting the phenylephrine? And do you move the needle around when you inject it, or you just do it in one area?
No, it's a good question. As always, when you puncture the tunica albuginea, you can feel the change, so you know that you're in the corpora cavernosa. Then you aspirate. And if you're aspirating very thick, viscous blood, you know you're not in the artery. If you do hit the artery, then you know you'll aspirate, you know, the bright red arterial blood.
I mean, I'm not as experienced as Jennifer is, but we have had probably over the 15 years, I've probably seen like maybe 4 cases where I've had to do this. And you are absolutely right about the draining into the container thing not working at all. Because I remember there was one case where we pulled off like multiple 20 cc syringes full, and still there was no detumescence. So yeah, it's not subtle at all.
Yeah, after trialing all these different techniques on our one patient, we just went to directly with phenylephrine injection. We didn't even try the drainage and aspiration anymore.
Well, thanks, Nick. That was a great talk. Like I said, I think a couple of us have all experienced it as well. I said, one of the pharmacists that I work at, they kind of gotten used to me having to use it, do a couple times, and so they've actually made little TB syringes for me, a phenylephrine pre-made for me almost. I was like, this is what I need, and they said, yep, we remember this from last couple times. And they made like little TB syringes, so you could have like phenylephrine loaded at appropriate dosing and stuff like that, so you could kind of do your injections, which was kind of a nice, like made it extra easy. All right, I think we're going to be moving along onto the strangulation law. I don't see any other new questions on there, so go ahead.
Okay, so the Michigan strangulation law. Everyone should be able to my screen. Jeff, can I get a thumbs up? Make sure. Perfect. So Michigan domestic violence strangulation law. Let me give a little background to why I'm talking about this. Like I said, I've been teaching at Michigan State for about 12, 14 years now, and I teach cross-curricular. I'm course director for a couple courses. I give emergency medicine lectures in different courses. I sit on committees, do curriculum stuff. And about 10 years ago, the course director for the female reproductive course, the OBGYN course, called me and said, hey, you're an ER doc. Part of the content that we deliver in the female reproductive course is management of the victim of domestic violence and management of the victim of sexual assault. Would you be interested in giving those presentations? So I said, sure, of course I would. So I designed those presentations, not only on the medical management of these patients, but also keeping in mind the laws that were held to as physicians and as emergency medicine physicians. And during that time, the laws have changed. I'll talk about that later on in the lecture. And I've actually had to change my presentation to them based on the changing laws. So because I kind of keep my eyes and ears open for these changing laws, I've kind of taken a subspecialty niche interest in the criminal justice advocacy that we as emergency physicians can provide for our patients. Along with that, for whatever reasons, I think it's just statistical improbabilities, but I get called all the time to go to court to testify in cases. I've testified in multiple murder cases, attempted murder cases, sexual assault cases, felon in possession of firearm cases. I'm always called as a material witness, so they don't pay me. I never get called as an expert witness to give an expert opinion where I can actually charge them. But for whatever reason, even amongst the other physicians that work at my same shop, I get called to co-testify in court. So not sure why, but it does kind of fit my interest in our physician advocacy for our patients in the criminal justice system. So what happened is a couple years ago, the Strangulation Law popped up, and because I kind of keep my eyes and ears open for new things that happen with these laws, I looked into it a little bit more, and then I designed this presentation, just to share this interest and this information with my residents. And same thing, Therese and Jeff, found out that I give this and thought this one might be good for the group, so I'd be happy to present. So same things. I haven't gained any new conflicts of interest, and I'm still had the same positions I've had before. So my objectives, by the end of this presentation, I want everyone here to be able to state the legal obligations of emergency medicine providers when we treat victims of domestic violence. I want us to identify strangulation as a unique risk factor for mortality in victims of domestic violence. And I want to state the physical and physiological effects of strangulation. So a couple of laws I want to go just as backdrop laws, so just so we have a context in the field that we're working in. So under Michigan law, domestic violence is defined as violence originating from one of these relationships. And I kind of like what they did. I think they did a good job, because violence isn't violence. Two guys, that bump into each other at the bar and start slugging it out. That's a different type of violence than domestic violence, people with a pre-existing relationship. The question is, the difficulty comes in defining what the pre-existing relationships are. So I think Michigan law does a pretty good job of defining what a domestic relationship would be. They say a spouse, either current spouse or former spouse, someone who is dating, either currently dating or formerly dating, and they go on to say what dating does and doesn't mean. Someone who has a child in common, because that doesn't necessarily mean they're your spouse or even someone you've dated before, but if you have a child in common, that's a domestic relationship. Or residents of the same household, whether you currently live in the same household or used to live in the same household. So if you meet any of these conditions, you're now in a domestic relationship, and if violence occurs, it's considered domestic violence. Now, under the law, what I do like too is that they say for domestic violence to occur, it does not require proof of any injury. So reporting of domestic violence falls under the domestic violence law. And so the perpetrator of domestic violence, even if there's not a mark on the victim, can be held accountable in the legal system. And I think that's certainly appropriate. The first offense for domestic violence it's a misdemeanor. It's 93 days in jail. And the second offense, it's up to 1 year in jail. Now, I refer to this as simple domestic violence. I don't like that term. I don't have a better term for it. But the reason is because this law is in direct contrast with what's called aggravated domestic violence. Different law. Aggravated domestic violence is domestic violence that meets any of the above criteria, people in this domestic relationships. But it's an injury that requires immediate medical treatment or that causes disfigurement, impairment, or impairment of health or impairment of body parts. So what that means is if a patient who's in a domestic relationship comes in with an injury that requires treatment by us, that's now aggravated domestic violence, and the consequences for the perpetrator are quite a bit higher. So it's still a misdemeanor, but it's up to 1 year in jail for a first offense and up to 5 years in prison for a second offense. So aggravated domestic violence is quite a bit bigger deal in the criminal justice system than what I refer to as simple domestic violence. And it's important for us to know that too, because as we're talking to our patients, we're eliciting injuries and we're trying to get the medical history. So when we see victims of violence, we ask, were there weapons involved? Were you pushed? Were you thrown to the ground? Were you punched? Because we're trying to elicit trying to determine the extent of injuries and where we need to look for injuries, which is completely appropriate. But if we can help the legal system connect the dots, where we can say, this person was the named person who punched you, you now have an inferior orbital wall fracture, we can now connect the dots that this is now an aggravated domestic violence, and we can better advocate for our patients in the criminal justice system. So it's important for us to know about these two laws. The other law I want to bring up just as a background context is this law, which is we as healthcare providers are required to notify the police if we see a patient who is a victim of a violent act. So they define that as suffering from a wound by means of a knife, gun, pistol, or other deadly weapon, or they leave a very open end here by any other means of violence. And this is a big deal for us in emergency medicine. because this means if we see a patient with injuries due to a violent act, we have to notify the police. We're required by law to notify the police. This is different than the mandated reporter laws. The mandated reporter laws are for vulnerable populations, the elderly or children, where if we suspect abuse, we have to notify the authorities and they can then investigate, see if abuse even occurs. This is different. These are not a vulnerable population. So we don't have to report suspected violence, but if someone comes in with an injury due to violence, we have to notify the police. This was a big deal for me because when I give the domestic violence presentation at Michigan State to the students, the theme I use, the principle I use is is empowerment of the victim. Our goal as providers is to treat their injuries, but also begin systemic re-empowerment of the victim. And often our well-intended efforts of intervening and getting them the patient to shelters or getting them resources can not only make things worse for the patient, but it's us making decisions for the patient instead of the patient empowering to make themselves. So when this law came out, it really changed and it was against my principle of the model that I was preaching and teaching about how we have to treat these patients. As it turned out to work out pretty well. I was wrong because what this law forced me to do is instead of passively empowering the patient. So specifically, I would talk to the patient. I would say, hey, obviously this is an injury due to a violent act. Before this law, I would say, you don't need to talk to the police if you don't want to. It's completely up to you. If you want me to call them, I will. If you don't, I won't. And if they say no, I would passively walk away. What this law has forced me to do is have a conversation with the patient. I would let them know, look, I have to notify the police. It's the law that I have to do so. But you are empowered. If you want to make a report, you can. If you want to tell them what happened, you can. If you don't want to, you don't have to. And so what that did is shifted the focus a little bit for me, passively empowering and not doing what they don't want me to do, to actively telling them that they want that they're in control. So this actually in application worked out to be pretty good. And I think it, in my experience, has been a good law that benefits our patients. So with those three laws, the context, as the background context, let's talk about the Strangulation Law in particular. What happened was in the early 2000s, there were a bunch of domestic violence studies in the public health literature. And through all the domestic violence studies, one unique characteristic rose to the surface. And they found out that patients in domestic violence situations that were strangled, where they were either manual strangulation, hands around the neck, or ligature strangulation, had 7 times increased mortality over patients who were in domestic violence relationships that didn't involve strangulation. And that fits the context which, the model under which I taught domestic violence too, because well, the one model that I promote in domestic violence is that the motivation of the perpetrator of the violence isn't necessarily to cause violence, is to use violence in all of its form, physical, emotional, sexual, financial, isolation, to systematically disempower another person, to maintain power and control over another human being. And they will use any form of violence to do so. Strangulation is different. When domestic violence involves strangulation, that's a perpetrator wanting to kill the other person. And when that became identified as, when strangulation became identified as a unique characteristic that increased mortality, the Michigan legislature did something about it. So they passed this law, which identified strangulation as intentionally impeding the normal breathing or circulation of the blood by applying pressure on the throat or neck. But what it did is, if strangulation occurs in a domestic violence relationship, it's an automatic felony. None of this 93 days misdemeanor. It's an automatic felony, up to 10 years in prison. But it's important for us to know, because as we're gathering information from our patient about the injury, were you kicked, were you punched, were you thrown down, it's important for us to ask if they were strangled. Because if they were strangled, that makes a huge difference. Even if it doesn't make a difference in our medical management, it makes a huge difference down the road in the criminal justice system and our ability to advocate for this patient. So if the patient says, yes, they put their hands around my neck, or they put an object, a rope, a cord around my neck, that's a very big difference, not only in the mortality of this patient, but in the downstream criminal justice ramifications for the perpetrator. So if we get called on to testify in court, let's talk about how strangulation works. So the way, because defense attorneys can and will try to discredit us, especially if their client is facing serious prison time. In fact, the last case I testified in was the sexual assault case. The defense attorney went in a direction I did not expect them to go to and started asking questions I did not expect them to go to. And I'll talk about that in a minute. So the way strangulation works. So you've got strangulation either using manual, using the hands, or using a ligature. There's 3 different structures that can be compressed. The first is the trachea. I'm not really going to talk about that, because if someone compresses the trachea to the point of fracturing the trachea, that's not subtle. That's advanced airway techniques. That's intubation. Those are things that are not subtle findings for us to be able to identify. So I'm really not even going to talk about tracheal injury. I'm going to talk about carotid and jugular strangulation. So if someone applies enough pressure while strangulating another person, and I apologize because these are kind of graphic talks, but if someone provides enough pressure to occlude the carotid artery, and it's about 11 pounds per square inch of pressure. To put that in context, an adult male handshake is about 80 to 100 PSI. So that's not a lot of pressure to occlude the carotid artery. Now, if you occlude the carotid artery, within seconds you get rapid asphyxiation, and if the strangulation is not resolved, the patient dies. But if the strangulation, after the patient becomes unconscious, is resolved and the patient regains consciousness, they get long and short-term encephalopathy. And encephalopathy meaning confusion, meaning memory loss, meaning cognitive problems. And that's important for us to know, because when we're talking to the patient and we say, hey, was there any strangulation involved in this assault? And they say, yes, they choked me until I passed out. But then they don't remember what happened after. They don't really remember what happened before. They're kind of confused about details. That's not a patient being evasive. That's a patient demonstrating short-term encephalopathy. And that's something for us to be able to recognize. And that's something to be able for us to be able to testify if called upon to do so. So if we're called in court and the defense attorney says, now the patient says they were strangled until they passed out, but they don't remember, they can't provide details, you know, how credible is that information? We can now say that's consistent with encephalopathy, which is very consistent with asphyxiation. So it's important for us to recognize short-term encephalopathy as a result of asphyxiation. And it only takes about 11 PSI of pressure to do that, to occlude the carotid artery causing asphyxiation. The second structure that gets occluded during strangulation is the jugular vein. Now, the jugular vein, if the perpetrator is strangulating in between 4.4 pounds a square inch and 11 pounds per square inch, so they're not choking the patient out, they're not choking the victim out where the patient passes out, but rather they have their hands around the patient's neck for a prolonged period of time. What that can do is cause venous congestion and increase pressure proximal to the area where that's occluded. And when you have increased venous pressure proximal to the occlusion, you get a couple different findings, mostly petechiae. And petechiae, I equate to epsilon waves on the EKG. They're very subtle, and unless you're looking for them, you're not going to find them. You're not going to notice them. So where do we look for petechiae in someone who presents with a history of strangulation? We look for, first of all, on the skin. This one's pretty obvious, the petechiae, but this is a light-skinned individual. In a dark-skinned individual, you can see where this would be a lot more difficult to identify unless we're particularly looking for them. We also look for petechiae in the conjunctiva. And again, look, in this patient, you even had to pull down the eyelid. And the petechiae, here's the ruptured capillaries right in this area. Unless you're particularly looking for them, could be very easy to overlook and not notice. Here's a couple other petechiae over here. You can also have petechiae in the posterior pharynx. Posterior pharynx, you've got the normal vascular meshwork, but you've got a couple areas here where you have ruptured capillaries. You have ruptured capillaries. You have ruptured capillaries. Again, it's not necessarily obvious. So unless we are looking for it, we're not going to notice those. But if we have a patient in front of us who reports a history of strangulation, and they say, yes, he had his hands around me for a prolonged period of time, and we look and we notice and can document petechiae, that provides a lot more credibility to the fact that strangulation even occurred, and has a lot more powerful downstream effects in our ability to advocate for our patient. So recognize and look for petechiae in a patient who reports a history of strangulation. Now, the third type of injury to notice is bruising. Bruising, if you notice, and I'm really hesitant to use 15 pounds per square inch as a definitive number. One, because my reference is Google. I just Googled it and I couldn't track down the original reference. But two, the second reason is there's a lot of factors that can contribute to whether or not bruising occurs or not. It's not simple pressure, and that came up, actually, I mentioned the sexual assault case I testified in a couple of years ago. What had happened is the assailant had the victim in the car. He was in the driver's seat, she was in the passenger seat, and he started punching her until she acquiesced and submitted and allowed him to sexually assault her. And then in my documentation, when I saw the patient after the assault, I documented mild hyperemia on the left side of her face, which is consistent with her where she was sitting. What was surprising to me was the defense attorney in questioning me in cross-examination. His approach was, he said, "Hey, look at my client. He's this huge guy. Look at the victim. She's a tiny female. Wouldn't you think that if he punched her that hard, you would have more bruising than that?" And I didn't expect that line of question. I didn't expect that. Luckily, I didn't get too rattled and kept my wits about me and appropriately testified that no, there are a lot of factors that are contribute to the amount of bruising, and someone can get punched very hard and have very direct, very, very severe injuries to their skin without evidence of bruising. And so without a cliffhanger, the patient was found guilty, not because of my testimony. There was prior sexual assaults and a lot of DNA evidence, but he's currently in prison and will be for a very long time. But the point is, bruising occurs at levels higher pressure than occlusion of the jugular or occlusion of the carotid artery. So you can have significant choking damage, including death, without a single external mark, without a single mark on the skin. So the lack of bruising does not indicate a lack of choking. It does not indicate a lack of strangulation. In fact, most strangulations, even deadly strangulations, occur without any external bruising at all. So if we're called upon to testify and the attorney says, "Is it really possible to choke somebody out and to strangle somebody with that level without leaving a mark on their skin?" The answer is yes, it's very possible to cause severe choking without having a mark on the skin. If there are marks on the skin, they're either in the form of manual strangulation or ligature marks. The recommendation is not to describe them as manual strangulation or ligature marks, just describe the, either draw pictures or describe the pattern of bruising, because if the patient doesn't remember and they said they're manually strangulated but then remembers that they were ligature strangulated, but we said they're consistent with fingers, that could cause questions in the credibility of the testimony. So we just provide the objective evidence. We say bruising this pattern. If we're called upon to testify, let the lawyers connect the dots and say, is that consistent with manual strangulation? We can then say yes. One more slide, just to look as a different visual reminder of things to look out for in victims of strangulation. One, we look for signs of encephalopathy, memory loss, cognitive changes, behavior changes, confusion. We look for physical signs, petechiae. We can look for petechiae in the skin. We can look for petechiae in the conjunctiva. We look for petechiae in the posterior pharynx. And then we look for signs of external bruising. That is my presentation. The take-home points are, as emergency physicians, we may be called upon to testify on the behalf of and advocate for our patients in the criminal justice system. There are several different laws we need to keep in mind when doing so. Strangulation is a different level of domestic violence than the other types of domestic violence. That's attempted murder and is treated appropriately as such in the medical legal system. So we need to know that. We need to ask our patients about that, and we need to look for injuries consistent with that. We need to look for encephalopathy, petechiae, and bruising. And we also need to know that the majority of strangulations have no external signs. And I reiterated that twice because it's very consistent with strangulation to not have any external signs, and we can be called upon to testify to do so. That's it. I do want to give appreciation to my best friend, Jim, since childhood. He is actually a criminal defense attorney. I had him look over these slides to verify my understanding of the laws, and he verified that my understanding is correct. So I will now open to any questions.
Hey, Nick, Sandy Veter. So we had an interesting situation where we had a strangulation victim in our emergency department, and she had obvious injuries, but she absolutely refused to file a report, would not speak with police. And the question came up whether we had an obligation to still contact the police despite the patient not giving us consent. Any thoughts on that?
Yes, you do. If there is an obvious assault causing an injury, as providers, we have to notify the police. I tell the patient, I have to notify them. It's a law that I have to. That's been my empowerment speech. You don't have to you don't have to file a report if you don't want to. They're going to come talk to you. You can excuse it. That's fine. But no, it is our obligation. We have to notify the police.
Thanks.
Hey, Sandy, this is Brad Walters. We have found that the Haven folks have been incredibly good at helping us in those situations. Usually the victim is so fearful for themselves that, you know, they've been told by the perpetrator, hey, if you go to the police, you know, something bad will happen to you. But that has been very helpful when I've been faced with that reluctance to let us help them further.
All right, so we're gonna kind of get going. We're a little bit behind now. I think if the first Dr. Bucky would like to maybe answer some questions in the chat, that might be helpful. We are gonna take about a 5-minute break. We wanted to make sure we thank our sponsors again for ProAssurance, so that we're able to offer the CME for free, and then the educational grant from the Portoral Pharmaceuticals, who we'll hear about a little bit later. I think Dr. Andrew Bucky has, or Drew Budke would like to give an announcement kind of before we go on to start our break, just to kind of get stuff going for his lecture that we'll have after.
Absolutely. Thanks, Abby. So for this next little bit, we're doing an interactive ultrasound session. I was hoping that I could put up a slide to introduce how we'll get to that other platform. Everything's staying in Zoom, but to mix and match up what's going on technology-wise, we're going to be doing the ultrasound session in a game called Kahoot. If I share my screen here, everyone can feel free to break out your cell phones or open up a separate browser window, and that way each of us will interactively be playing this game while we're still here in Zoom going over all the content. It'll make a lot more sense if you can just see what I'm about to show you here. So as we break out, you can take a moment to troubleshoot the technological side, but it should be very, very easy. The instructions are right here at the top. Just go on your phone browser or on a new web browser to www.kahoot.it. Notice it's not .com, it's .it, and type in this code. Whatever name you want to put in, we'll log you into this page, and understand about 5 minutes. We'll come on back and we'll kick things off, okay?
Yep, so we'll take about a 5-minute break and then play a fun game of ultrasound Kahoot. All right.
All right, my clock shows it's been 5 minutes, Dr. Bucky, so I'm going to give you an introduction and get you started here. So welcome back, everyone. Thanks for letting us have just a very quick break to let you refill your coffees or microwave your coffee in my case. And it is my great pleasure to welcome Dr. Drew Bucky here to the conference. He is going to wake us all up with Kahoot. And Dr. Bucky is the Assistant Program Director for the McLaren Oakland Residency Program, Emergency Medicine, and also has extensive ultrasound expertise. So we're going to be hearing about ultrasound today, as he's the Adjunct Program Director of the Fellowship in Ultrasound at Wayne State, I do believe. So Dr. Bucky, the show is yours. Have fun.
Wonderful. Thanks, Reese. So I'm broadcasting at you live here from beautiful sunny Alaska. I split my time between Detroit and Pontiac and up here in Alaska. And so I hope we have no technology issues. We typically don't, and I've done this in the past. I'd like to also introduce Dr. Nasser Bazoun. He's the current fellow downtown in Detroit, and he's waving Nass right now. He's going to be helping me give some color commentary on some of these cases. It looks like we only have a fraction of our participants in the Kahoot game. There is no prize money to be won, and so you're not losing out on anything other than hopefully some fun and some education. But if anybody wants to unmute really quickly, if you're having some tech difficulties, I can take a brief moment to help you out. If not, we'll proceed and go ahead and watch along and pick one of these people on the screen to root for. Does anyone have any problems or concerns that's keeping them from getting in? Okay.
Yeah, Dr. Bucky, mine is saying that the pin isn't recognized.
Huh. I guess try making sure you don't have caps lock on, and that's the number at the top. I'm not familiar with that particular error. I'm going to go ahead and say user error on that one, Omar. Oh. Okay, well, otherwise, go ahead and pick someone to root for. I know we're strapped for time at the moment, so I want to get to the good, juicy ultrasound stuff. The point of this lecture is to just kind of crack the ice with some very cool ultrasound topics and to kind of reinforce how approachable ultrasound is. My objective to take away from the next 15, 20 minutes, there's only about a dozen questions here that we have, and it goes quick. But I wanted to highlight, just kind of hand curate a couple of cases, about a dozen different instances from head to toe, in which the addition of point of care ultrasound really had a critical role in achieving a good outcome. And maybe it was patient satisfaction or speed or comfort, maybe it was actual life-saving medical diagnosis, the whole gamut. And if you are not, say a complete ultrasound genius like Dr. Brackney, you don't have to be. You can make a positive impact in your patients' lives just by picking up the probe and sticking it somewhere on the body. And that's going to be the recurring theme of these cases. And I hope that if you take nothing away from these next couple moments, other than having some fun and switching up the typical Zoom conference, I hope you'll take away this idea that you don't have to be an expert in ultrasound. You just have to put some gel on the probe and stick it where it hurts on the patient. And I'm not exaggerating. That's the theme of a lot of these cases, that was what made a big difference in their care. You'll see what I mean. Let me show you some examples. First of all, Kahoot. It's just a color coordinated game. This is a warm-up question that hopefully just kind of gets us used to the format here. So this is a throwaway one. You'll see that you've got 4 different boxes you can pick from, and it corresponds to the options on the screen. So is this ultrasound clip? Is this heart, lung, duodenum, or the sustentaculum tali? You've got a timer on the left-hand side. We only have about 20 seconds for each one because I want to just keep this moving. We don't have too much time. And it looks like everyone has done a wonderful job. I'll show us this beautiful picture of a peripheral long axis view of the heart. We see the left atrium, the left ventricle. We're all on board with this. And so without further ado, let's get into the nuts and bolts of the game. You'll see that there's different points based on how quickly you answered, but it's way more important to get the question right than just to answer fast. Okamus is in the lead. Nicely done. All right, first good question. This is a patient who came in. She has a STEMI on her EKG. Uh-oh. But we noticed that it's identical to the STEMI she just had 3 months ago. So we stick an ultrasound probe on the heart. This is the apical four-chamber view, and we see something kind of goofy going on in here. Is this a Takotsubo? Is this STEMI with a regional wall motion abnormality? Is this an LV aneurysm? Or this is a third-degree heart block? Yeah, sure. You want to talk us through what we're seeing on this picture?
Yeah, I'd love to. So yeah, it looks like most people had LV aneurysm, which is correct. What we're looking at is an apical chamber view, and the infrareceptor wall is like sort of a focally dilated. You know, so I could imagine some people thought Takotsubo potentially, but of course the EKG is not going to be identical to the recent STEMI one. You'd also see more symmetric dilation of LV. Here we just see it in the infrareceptal wall, consistent with their prior STEMI.
So yeah, this is a great case that just kind of highlights that this patient, if all we were going by was one single EKG, she would have been going right to the cath lab and gotten lytics or TPA, depending on where we're at in the shop. And she's not a patient in whom systemic TPA would have been of any help at all. And that would have been very tough to recognize without having this big, huge whopper just bulging out at us on ultrasound. All right, moving on. Let's see. Oh, a little jockeying for pole position here on the leaderboard. Let's do one more question here. And this 15-month-old. Now we're going into peds. It's a 15-month-old with bilious emesis. What is going on in the center of the screen here? We've got about 14 seconds left to chime in as whether you think it's pyloric stenosis, a volvulus, intussusception, or jejunal atresia. This is a series of cases. I've seen this multiple times just in the last couple of years. It looks like we're split right down the middle between pyloric stenosis and intussusception. This is an intussusception. This is a target sign that you can see right here, and that's the intussusception inside the intussuscepient. And this is just a loop of one bit of bowel sliding into the next. Now, I was very surprised to learn when I called for a narrow enema on this patient, and the radiologist, interventional radiologist asked, which quadrant is this intussusception in? And I kind of thought that they were all equal at one point. And further study, I was taught and learned that other quadrants other than the right lower quadrant don't really matter as much. Why is that, Nasser?
Well, the ileocecal intussusception, which you'll find at lower quadrant, is the one that is most likely to be occurring as of a lead point lymphoid tissue and unlikely to reduce without an enema. The other one's kind of intussusception, and then it goes away, intussusception goes away, gives you that sort of colicky abdominal pain that comes and goes. But if it's in the right lower quadrant, specifically an ileocecal intussusception, the patient's going to need a little help to get there.
Yeah, I hope it's not just me. I'm getting just a little bit of breakup static with you, Nasser, so I'm sorry about that. But yeah, just to reiterate, it's the right lower quadrant ones that get stuck. If it's ileocecal, they'll actually get stuck. If it's just an ileal or a jejunal, those are physiologic. You just might have some enteritis, you'll have a lymph node, a wave of paracelsus comes by, it snags some bowel and goes for a ride in the adjacent loop of bowel, and that reduces on its own every single time. It's those ones that are in the, that might be the cause of why they're having bilious emesis, but it'll spontaneously reduce. In fact, actually, I have a nice little clip here that shows an ileal intussusception, and it's already spontaneously reducing without us having to do anything. So this is it in the long axis. Here's the obstructed segment. We see it already starting to unwind, and flow is intermittently getting restored again as it unwinds. And so this kid, he was vomiting bile, but it was only when this was intussuscepted, and as this resolved, his vomiting resolves. And so these are the kids that you'll observe overnight. They'll be fine. They don't necessarily need the intervention. If it's right lower quadrant, they may. All right, so what's causing this patient's fever? This is a good one. So this is in the left thigh. Up here we see some subacute tissue. Here's some muscle striations, a little pennate appearance of the muscle fibers. We've got about 8 seconds left. Cellulitis, COVID, fournier's gangrene, pyedomyocytis. What do we think? And anybody who's not actively in the game, go ahead and just pick your favorite, and we'll go ahead and talk about it. Yeah, while this is a very widespread, no one thought COVID. I was a little bit bummed about that. But here we're not just seeing some cellulitis, some inflammation in the subcutaneous tissue up here, but in the muscle fibers itself, we're seeing extension of these pockets of abscess and pus. And so this is the pockets of pus in the muscle itself. It's a very rare finding to see, but this is kind of disseminated. This is disseminated infection, not just in tissue, but all the way into the muscle. So this is pyedomyocytis, and that has a much worse prognosis, usually associated with intravenous drug abuse. Cool, good good range on the questions there. Oh, and the leaderboard is checking up. Oh, good, me. I finally got in charge up in the front of the board. Okay, this is a scary, scary one. The CT was normal. This patient clinically had some infection down there, but the CT didn't show much. What does this ultrasound suggest? 4 more seconds. Do you think it's just not enough gel? Do you think there's some sub-Q emphysema, calcification, or testicular atresia? Yeah, everyone's on board with this one. This one is just terrifying in that, thank goodness the ER doc was confident enough to pick up the ultrasound probe, and they had this high index of suspicion. They obviously suspected that there's an infection in the soft tissue of the patient's scrotum. They got a CT for it, and it was that big slices. Missed it. It said no signs of infection on this, no Fourier, no Fourniers. But the ultrasound physician, the emergency physician was advocating for their patient. They're able to put plenty of gel on there. This air artifact that we're seeing that's destroying our image of the testicle isn't because there's not enough gel. In fact, we can actually see a little bit of tissue at the top of the screen. We see that the probe is making beautiful contact with the body, and it's coupled with gel. There's just no image below that because of all the subcutaneous air and the scrotal emphysema that's in there. And so it was only with much, much more work than should have been necessary that the ER physician was able to convince the urologist to take the patient to the OR because the CAT scan was normal, but clearly the condition was not. All right. Oh, we've got a big answer streak going on. All right, we're going through these pretty quick. Like I said, we're short on time, so I'm sparing a lot of the commentary and trying just to get this going for us. But this is a patient who had chest pain 6 days ago, and they were diagnosed with pericarditis. And echo at the time was normal. They actually went to the cath lab, and the cath lab was normal. And they came back saying, "I've got chest pain. It's exactly the same." And then you see this: is it pulsus paradoxus? Is it stunning? Is it hokum or AS? All right. Great. So this one is just this one has a little bit more bells and whistles, but we'll see that there's this big effusion around the heart, and it's not that complicated to get this relatively scary looking image. If you're not familiar with getting these, it's one button and you get this line that does a Doppler gate, and so putting it over mitral flow, we see these are the beats, and this is exactly what pulsus paradoxus looks like on ultrasound, and so we are wondering if this patient who has chest pain, they have known pericarditis, they didn't have an effusion 6 days ago on that echo, but they do now. Is this just a normal effusion, or is this someone who's developing tamponade physiology and they need to go get a window or a needle? We can't go by the size of the effusion. We all remember that it's not the size of the effusion that is worrisome here with pericardial effusions. It's how rapidly it accumulates and if it starts causing the abilities for the right ventricle to fill. And this is the earliest sign you'll see of that. A later finding is the diastolic collapse, but what we're seeing here is that from beat to beat going into the mitral valve, some beats are big, some beats are small, and this is what pulsus paradoxus looks like. Back in the good old days, we'd auscultate, we'd palpate the wrist, and we see that these big beats are the ones that we palpate, and these smaller beats, we can hear them all, but these smaller beats, we wouldn't necessarily be able to palpate, and that's the paradox, that we're hearing a beat, but we're not feeling it. And we can visually quantify that here from this caliper, we're at 91 centimeters per second versus down to 59. And any difference of more than about 20 or 30% is considered a significant beat-to-beat variation. And so this is a patient who's coming in with pericarditis and chest pain, and it's because they're developing tamponade. It's not a benign effusion. They have tamponade physiology, and they're going right to get a window. All right. Got the same top leaderboard. This is just a quick true or false, and this one I hope sparks a little bit of debate or conversation. Does this procedure shown require sedation? Now, granted, this one is requiring some familiarity with ultrasound to even know what's going on, but let me give you a hint that there's about an ouch, ouch, ouch thunk right about, I'd say there, boom. And now the patient says, boy, I feel a whole lot better. Now, so what are we looking at?
Looks like a humeral head reducing into the glenohumeral shoulder reduction.
Yeah, absolutely. So this is a live reduction. This is the pocket of intra-articular lidocaine. Here's the humerus as it's getting manipulated, and it's about to pop back into the into the cup. So here's the ball, here's the cup, our glenohumeral, our glenoid cup, and our humeral head. What I think is very interesting about including this slide for all of us, I've found an incredible utility in using ultrasound for shoulder dislocations. I've been able to walk into a burning down shop here in Alaska, and there's patients piled up in haul carts, and there's not a nurse to be found because we're getting overrun at the moment. And there's a person in the hallway with a dislocated shoulder. And I know on one hand, I'm not going to be able to get a room, much less supplies for conscious sedation, much less a nurse to run a sedation and to monitor the patient's breathing for the better part of an hour as we go and do that. That's not going to happen anytime soon at all. And so it's either going to be this patient's going to sit here in the haul cart for a couple hours until we can get taken care of, or I can give them a shot right into the joint. I can watch it go in with ultrasound guidance and confirm that it's already back in, and the patient can go on their way. Now, granted, if you're concerned about fracture at all, you'll want to get some radiology involved. But if it's something like they're swimming and it popped out, something relatively atraumatic, in my opinion, there's no necessary need to involve ionizing radiation at all. I think most of us would be more comfortable with some X-ray at some point in the process, and that's certainly reasonable. But just to go over what you're seeing on the screen, these exams are performed with a probe in the horizontal plane on the posterior aspect. So up on the screen is posterior, and most of these dislocations will be anterior. So you'll see the humeral head lower on the screen or in the anterior direction. They've been studying this a lot in recent years. Of course, nothing is 100% in medicine, but the most recent article that come out of Annals is indicating 100% sensitivity and specificity for shoulder dislocations. And we saw in that previous slide, these aren't subtle. When they're out, they're way out. And by using ultrasound instead of relying solely on X-rays, you're able to get these patients treated in their study at 2 different sites, combined average of 43 minutes faster. Also, I pulled this question recently to about 170 ultrasound enthusiasts in the Metro Detroit area. And the question was posed to what are we doing? What's kind of, in ultrasound circles, are we doing blocks? Are we doing ultrasound for these? Are we doing sedations? And it was neat to see that the answers were all over the board. It was probably about an even mix. And I think that reflects the true practice of medicine, that there's not one answer that has to be for anything, but the more tools we can have in our tool belt, the more versatile clinicians we can be. And I think it speaks highly to the fact that you can put these back in very effectively and with high patient satisfaction without needing sedation. Other times you might need the sedation, and so just let's add some tools. All right, this is a patient, it's a view of his calf. They come in with compartment syndrome saying, wow, this really hurts. I was just in the ER. They did an ultrasound for me and said they thought I had a DVT, but they did a formal ultrasound, didn't find one. They thought I had it so badly that they put me on Eliquis anyways, and now my calf hurts and is swollen. What's going on here in the middle? We got about 10 seconds left. Is that phlegmazia? Is it intramuscular hemorrhage? Is it an arterial thrombosis? Or is it an occult tibial plateau fracture? This is a hallmark case of sticking the probe on the patient changed everything. And so absolutely, this is intramuscular hemorrhage before. I'd never seen it before in my life until this patient walked in the door, and I stuck the probe where it hurt, and I saw this. And it doesn't take much to conclude that 1 + 1 = 2 here. They had calf pain after getting off a flight, and so the ER doc appropriately ordered a formal ultrasound. The formal ultrasound said no DVT, and that's because the tech did what the order told her to do. She looked at the venous tree of the lower extremity, looked in the popliteal fossa, she looked up at the femoral bifurcations, and in those areas there was no DVT. So if we reported that back to the physician, and the radiologist reported that in the venous part of the leg there was no DVT. The doc said, well, you still have calf pain, you're on a flight, I'm gonna get you on some Eliquis. I don't know why this person would have been spontaneously bleeding into their calf, what was initially causing their pain, but certainly Eliquis wasn't the right answer, and they had fulminant compartment syndrome by the time they made it to my ER just 3 hours later, and they went right to the OR, and they had a bleeding vessel that had to be surgically treated. And so the key difference, that it wasn't that I did anything that was particularly different, but the other physician had ordered a formal ultrasound to look at some other related part of the body, and an ultrasound that a physician uses just to put on where it hurts tells a very, very different story than getting a formal study elsewhere. And I think that's kind of the moral of the story, is that in the hands of a physician and being able to assess the part that actually is bothering the patient, we're able to get much more insight as to what's going on with their complaint, and by looking under the skin right where they are, other than sending them off for a different study. All right, as we're going into the final stretch, this patient is in extremis. What is the presumptive diagnosis? Nasser, can you tell us about what this picture is showing?
Yeah, a parasternal short axis view here, giving us a kind of cross-sectional axial view through the heart. On the right side of the screen, we've got the LV. Left side of the screen, we've got the RV. And you can see the interventricular septum is kind of bowing into the LV. So normally you would expect kind of like a donut shape to the LV here. But that's not at all what we're seeing. We're seeing it almost looks like a letter, almost looks like a capital D, and that's because right ventricular pressures are just so high, the interventricular septum is bowing into the left.
Was the D sign named after the city of Detroit?
That's correct, Dr. Bucky, it was.
I think that's probably it. But yeah, this is evidence of very, very high right side pressures. And so why remains to be determined in this patient. However, in clinical context, if the patient seems like they have a PE and they're in extremis on presentation, this is showing that they have acute, very high right side pressures, and you can connect the dots here and maybe perhaps get heparin drip going while you're trying to obtain other treatment modalities, which is exactly what happened in this patient. And she ended up going to the cath lab for catheter-directed TPA. And so that was within 30 seconds of patient's arrival, because she's coming in priority 1 and she's obviously very ill. Taking a quick look at this shows us a whole lot about heart physiology that we wouldn't necessarily know. Our differential would be much broader prior to this bit of information. All right, last question. This is probably my favorite ultrasound clip of all time. It's just a clean catch. It's the opposite of a clean kill. This is a clean save by an emergency medicine physician. The patient has no symptoms. They went to their PCP's office for a routine follow-up. They're found to have a pretty soft blood pressure. They attribute it to new blood pressure meds because they just saw their cardiologist a week ago. They had the pacer replaced. They went and had everything tuned up, got all their meds adjusted. And so the doc saw them and said, hey, why don't you just admit him to my service? The patient has, again, no complaints, normal EKG, normal x-ray, normal physical exam. What do you think is going on in this picture? Is it metoprolol? Is it renal failure? Is it myocarditis? Is it the new pacer? Yep, absolutely. So you guys, most people cottoned on that we can actually see a pacer right here in the right ventricle, and there's this big effusion. And this was a pump the brakes moment for my colleague who found this. And the reason I think it's so beautiful is that this was on a Friday in a shop that doesn't routinely do echoes. There's no way the echo would have been done until Monday. There's nothing else in our routine cardiac workup that would have given any hint that this patient has a perforated ventricle and has a pericardial effusion and is going to die over the weekend of this. There's nothing in traditional medicine that would have found this. He didn't have any complaints. He had a normal EKG. He had a completely normal chest x-ray. He didn't have the classic findings on physical exam. And because the physician said, it's a little bit slow in my shop right now, I've been hearing a lot about this ultrasound thing. I want to just practice. I've heard about this rush exam where I can use it to differentiate some undifferentiated hypotension. I guess that's what my patient has, even though it's probably just the new blood pressure meds he got put on. Let me just put the ultrasound on his chest. I'll see what I can look at. I just want to better myself as a physician. What's this guy's thought? And practice with this ultrasound. And by doing so, he stumbled across this. And this is not a really technically good echo. And that's why it's my favorite, is that this is a doc who didn't know what he was doing with ultrasound necessarily. He was trying to get better. He was trying to practice and embrace new things. And he stuck the probe on the chest. And he came across with this life-saving diagnosis without having perfect technique or perfect training. And I just think that's beautiful. And the patient went and made a complete full recovery, went right to the OR and had everything fixed. And so I wanted to end on that note, and hopefully it's just a little bit of a feel-good story and a little bit of an inspiration that that this is very approachable technology, and it's very important and can either expedite care or improve care or completely transform care. It's still just one tool in our armamentarium, but a really important one that I think is really fun to share and talk about. I hope you guys enjoyed this interactive experience. let's open up to the leaderboard. We'll see who won the MCEP EM Summer Series Ultrasound Challenge. In third place, we had SB. Very nice. Coming in silver was me. And number one, drum roll, please. Dr. Pez. Congratulations, Dr. Pez. Very nicely done. Are there any questions? And presenting right now.
Thanks, Dr. Bucky. That was absolutely a lot of fun. Not just because I won either. That was a really cool format. Sorry, I got to gloat for just 30 seconds. No, thank you. That was a lot of fun. Let's do it again sometime. I really enjoyed that, and I think it got everybody moving.
Absolutely.
All right. Do we have any questions for Dr. Bucky? All right. If not, then we're going to keep going on. Oh, I'm so impressed by the other Dr. Bucky. Yes. Thank you very much. We next are going to have a lecture by Dr. Chris Bao. I'm sorry if I'm saying that incorrectly. He's the Vice Chair of Clinical Affairs in the Department of Emergency Medicine at Brigham and Williams Hospital, and Associate Professor of Emergency Medicine at Harvard Medical School. We're going to talk about reversing direct oral anticoagulants in the ER.
Thank you. I'm just sharing my screen, and I'm going to have Mary give some introductory comments.
Thanks, Dr. Ba. Hi, everyone. Thank you for coming to today's CME event entitled Changing Course, Reversing Direct Oral Anticoagulants in the Emergency Department. Next slide, please. This activity is jointly provided by the American College of Emergency Physicians Inspire Learning and is supported by an educational grant from Portola Pharmaceuticals. Portola has had no involvement in the selection of faculty or in the content. Next slide, please. This event is designated for 1 AMA PRA Category 1 credit and is approved by the American College of Emergency Physicians for 1 hour of ACEP Category 1 credit. You should have an electronic meeting handout that includes the faculty bio disclosures and the activity objectives. Next slide. Our speaker will be Dr. Christopher Baugh from Brigham and Women's Hospital and Harvard Medical School. Next slide, please. If the speaker discusses off-label or investigational uses of products or devices not approved by the FDA, speaker will inform the audience that the use is off-label. Next slide, please. In order to receive credit, you must participate in the activity, including completing the pre-assessment and the post-meeting evaluation links. Full details are in your handout. I will be emailing instructions on how to claim your CME certificate after your evaluation is completed. Even if you aren't receiving credit, we value all feedback and we encourage participants to provide their feedback as it helps us develop future CME educational programming. There will be a Q&A session at the end of the meeting and attendees are encouraged to ask their questions using the Zoom chat box feature. And at this time, I'd like to turn it over to Dr. Baugh.
Thank you, Mary. I know I'm the last speaker and we're running a little over, so I'll do my best to get us caught up and also leave a little bit of time for Q&A at the end. And so the kind of goals for today are kind of laid out in this slide where we're going to talk about severe bleeding in the patient taking a DOAC, what kind of assessment you might be doing for that patient in terms of which agent they might be using, the timing of their last dose, the dosing that they're taking, and which testing you might be doing to inform your strategy. And then talking about which agents might be used to treat those patients. And then we'll talk a little bit about how your local protocol is going to need to support your care of the bleeding patient on a DOAC and ED. We can start with a case study. We have maybe 3 or 4 of these in the slide deck just to help put a face to this issue, which we all have likely seen in our clinical experience, right? The patient who's bleeding on a DOAC. And we'll kind of define DOACs in a couple of slides, but I think we're mostly familiar with that. So this is an 80-year-old gentleman, history of coronary disease, atrial fibrillation, comes in after a fall at home. EMS brings him in, backboarded, collared. He's a bit confused when you're questioning him. He's had some recent falls that he admits to in your initial history taking. On your evaluation, you find his GCS to be 14. You're taking a point off for the mild confusion. He is tachycardic to the 150s, but is normotensive to a little hypertensive. And then he is adding 95% with some slightly labored breathing. And then he does have a head lag that you notice. If we fast forward a little bit, after your primary, secondary evaluation, the patient's family also is able to come. You meet them in the waiting room, get a little bit more history, and find out that he's full code. And you have a med list that includes some cardiac meds, including diltiazem. He's on aspirin, lisinopril, and rivaroxaban, very relevant for the trauma patient with a head injury. Some of your labs come back not terribly abnormal or helpful in any way, and you continue your assessment. We're going to break away from that case and circle back to it in a few slides, but let's talk a little bit about anticoagulation treatment in the patients with atrial fibrillation. So for a very long time, this was typically warfarin was the mainstay, and then about 10 years ago, the DOACs came to market, initially with dabigatran, and then with rivaroxaban and apixaban, and then we have some newer 10A inhibitors in the last couple of years. And basically, when you compare these DOACs to warfarin, what you see are similar rates of ischemic stroke, and that's why we put these patients on blood thinners with a history of atrial fibrillation to prevent ischemic stroke, which has incredibly high morbidity and mortality, and we'll talk about that in a moment. But the advantages of the DOAC class when they've gone head-to-head against warfarin is that you see a lot less intracranial hemorrhage, about half as many cases for this indication of atrial fibrillation. You also see less overall cases of major bleeding, but you do see a higher incidence of GI bleeding. And that kind of net effect of increased GI bleeding, less intracranial bleeding, leads to decreased risk of death of about 10% net. If you look at the time before we had drug-specific reversal agents, so this is a study from 2015, when you're treating apixaban head bleeds with PCCs mostly versus warfarin head bleeds that you're also treating with PCCs, very similar mortality in those populations. So this is a 30-day case fatality rate of about 43%, so quite high in that intracranial hemorrhage population. And then if you look at, once you introduce agent-specific reversal agents, so aduracizumab, which we'll talk about in a few slides, for dabigatran on the left, showing a 16% 30-day death for intracranial hemorrhage, and topic of this talk is how to assess and treat those patients. You also, I've seen patients who are on Coumadin and aspirin, or Coumadin and Plavix, or some other combination of a 10A inhibitor plus an antiplatelet agent, and they're also at higher risk for bleeding. So when an event happens, whether it's a thrombotic event. And on the left, we have an example of an ischemic stroke. And on the right, we have a bleeding event, so major bleeding. It could be GI bleeding, could be intracranial bleeding. There's a huge expense associated with those events. So we're trying to keep those patients in the sweet spot to prevent bad outcomes for them is the main clinical reason to do that. And then when they have an event on either end of that spectrum, it's incredibly costly. And so there's a lot of reason to get it right, get the patient right in that sweet spot middle. I mentioned before that we're going to be seeing a lot more patients on DOAC therapy. It's becoming kind of the dominant strategy when you're talking about anticoagulating patients who have an indication for anticoagulation. I'm kind of focusing mostly on the two major DOACs that are currently being used in the US, which is apixaban and rivaroxaban. Apixaban has the main indications of atrial fibrillation and VTE. Rivaroxaban has some newer indications for chronic coronary disease. So this is someone post-cath. We wouldn't be starting them on this from the emergency department, a cardiologist would, or peripheral arterial disease. And so that's a vascular surgeon or vascular medicine specialist might be starting patients on that for that indication. And those indications are going to have a different dosing than the AFib or VTE indications that we're probably most commonly writing for patients who we diagnose those as kind of new processes. So someone with an uncomplicated DVT in the ED, we might be starting them on one of these agents and sending them home rather than admitting them to the hospital like we might have done years ago. So we're going to kind of pivot a little bit to how to assess and manage major bleeding in these patients. So this diagram, it's a little busy. I think I'm another slide or two kind of zero in on the left side, which is the DOAC classes. On the right is more warfarin and parental anticoagulants. This is taken directly from a figure that's going to show in a paper that I wrote that's going to be published in next month's Annals of Emergency Medicine. That is an expert panel kind of consensus statement on the assessment and treatment of patients who are bleeding on anticoagulants. And so if you, one thing to also mention is that a companion resource to that paper is an MPOC tool. So I don't know how many of you have this app. It's available in the App Store for Apple and Google. And it has several conditions right now, including atrial fibrillation that I contributed to. It's meant to be a bedside tool to help clinicians kind of sort out how to assess and treat different conditions. And so reversal of the bleeding anticoagulated patient is going to be one of these tools. And so there's a screenshot of that on the right side of the screen. So that will be launched next month as well. Not currently available, but will be shortly. And so encourage you to look into that if you find this helpful. So zooming in, as I promised, to the DOACs. And so we have the direct thrombin inhibitor and anti-10A inhibitor. Those are kind of what constitute the DOAC class. You look at kind of when the timing of the last dose could be relevant. And I mention that because assuming the patient has normal excretion of the drug half-life and metabolism will clear the drug given enough time. And so it's a very relevant question if you're talking about giving a reversal agent, because one strategy could be just to wait and see, right? That could be a reasonable way to approach these patients. And so getting a sense of the timing of the last dose is going to be an important part, as well as which agent they're taking, right? Because you have agent-specific treatments. And so giving duracizumab to the rivaroxaban patient is not going to help that patient. And so you need to know with some high confidence which agent they were taking and when they last took it. You can see that under tier 1, we have some targeted reversal agents, and we'll talk about what makes them targeted in a few slides. And then tier 2 is kind of the not targeted option, which is another way to treat these patients using PCCs that will basically give back the factor that's inactivated by these anticoagulants, right? So for the rivaroxaban and apixaban, you're going to be giving factor 10 in the PCC, and you're going to saturate that drug and then have enough left over for the patient's normal coagulation to occur and for their bleeding to get better. Whereas andexanet alpha is going to reversibly bind up as a 10A decoy and inactivate that drug. So it's a totally different mechanism of treating that patient. So just like in almost anything else in emergency medicine, when you have a patient who you're seeing who's bleeding on a blood thinner, it's important to do to take a step back and do do your ABCs, make sure you have good access, take a good history, send off labs. We can talk about, whether you want to wait for labs to come back before making decisions in a few slides from now. If you have the opportunity for source control, that's great. If someone's having like a bleeding dialysis fistula, it might make more sense to get kind of mechanical control of that bleeding fistula as a step, before considering any reversal agent, right? So don't forget those kind of initial steps that could be very important or even more important than reversal. I've used the term major bleeding a couple times in this slide. I think it's important to have a very specific definition of what major bleeding means. I like to think very concretely about kind of who meets criteria for these drugs and who does not. And so you'll see in the paper that comes out next month, we do kind of make a recommendation on how to define this. And this should show up in your local hospital's anticoagulation reversal policy, which you should have one. And if you don't know if you have one, you should look into it. And if you don't have one, you should lead creating one, right? Because you need the resources and pathway to support the emergency physician having access to timely reversal agents. Whatever you have on formulary, you need to be able to get access to it with minimal delay or gatekeepers. And so for what I would call a life-threatening bleed, this is usually a high volume bleed. And typically GI bleed, but it doesn't have to be. It could be like a retroperitoneal bleed. To me, it's one of three conditions, one or more of three conditions are met. So the first condition is a large hemoglobin drop from a known previous value, and transfusion is ongoing, right? So that to me would meet criteria. The other is an uncontrolled bleed. So you can't get source control. The patient's going to go to IR to embolize a pelvic vessel from a pelvic fracture. That would be criteria for life-threatening bleed. And then the last is the patients who are, for whom you're reaching for vasopressors to support them. They're in hemorrhagic shock to the point where, in addition to volume, you're also reaching for pressors. So the GI bleeder that you're putting on pressors, in addition to maybe activating a massive transfusion protocol, that's a clue to you that reversal is probably indicated for that patient. If you move away from that kind of large volume bleed, there might be other patients who would need reversal. And so to me, those are the patients who aren't bleeding a lot, but they're bleeding in an area where even a small amount of blood could be causing death or permanent disability, such that reversal is kind of worthwhile. And so the head bleed or the brain bleed is going to be the kind of number 1, 2, and 3 in this category. But you can think of other things, right? So the spinal cord hematoma, the aortic dissection, the pericardial tamponade with hemopericardium. Those are other areas where it would make sense to reach for reversal. And then the last category is the patient who's going to have an emergent surgery or procedure that can't be delayed and has one of these blood thinners on board. And that procedure itself carries a high risk of bleeding. And so typically the answer in this category is to just hold off on the procedure or empirically treat. And so for the patient with concern for meningitis, the typical answer for someone who's on a DOAC is just to give meningitis treatment and not do a lumbar puncture, right? And that can be that's typically the right answer. But if you have an example where someone has to go to the OR, they have, peritonitis from a perforated appendix, and they're in septic shock, and they need to go to the OR, and they just took a dose of a DOAC, and the surgeon is worried about bleeding. That's a conversation with the surgeon, and it's notable that the durasizumab did study the use in urgent surgery or emergent surgery, and does have an FDA approval for that, whereas andexanet alpha does not have that indication currently. There's an ongoing study to see if that indication will be added, but as of now, it's not an indication. So circling back to our gentleman who had the fall on rivaroxaban with an obvious head injury, you get him to CT pretty quickly, right? That's going to be part of his evaluation. You're going to scan through at least his head and cervical spine and do some chest wall concerns, maybe his chest as well. And you see this on the right side, right? So he has an acute bleed. He's on rivaroxaban. and you need to think about kind of what other information you might need before reaching for a reversal agent, or maybe you're already talking to your ED pharmacist, if you happen to have one, about getting rivaroxaban or PCCs if you have that available and don't have access to an andexanet alpha to treat the rivaroxaban head bleed. And so if we circle in on the rivaroxaban box here, we know that 8 to 12 hours is kind of the timing where giving a reversal agent would be relevant. If it's way out of that window and the patient seems to be stable, you can kind of consider, right? It's a case by case. I would say with a bleed that significant and with some confusion, even if it was a bit out of this window, I would still be thinking about reversal. And again, your kind of reversal options are going to be andexanet alpha or PCC for rivaroxaban. I mentioned before about, with that big asterisk, is assuming that excretion is normal is an important consideration, mostly for dabigatran, because dabigatran, you can see how it's an outlier in the renal secretion category here, all the way in the upper left box. And so a scenario that I've certainly encountered is a patient on dabigatran who is dehydrated, has an acute renal injury, has decreased elimination of dabigatran, and even though it's been a bit of time since their last dose, they still could be having drug effect, and if they're bleeding in that scenario, you would want to extend that window to consider them a candidate for reversal. Let's talk a little bit about what blood tests might be helpful in these patients. And so, typically your coagulation studies that most of us have access to all the time are going to be your PT-INR and PTT. We're kind of rarely going much outside of those for coagulation studies. There is a concept of an anti-10A assay. So these are kind of calibrated for specific drugs. So you're like a Pixaban anti-10A assay. I would say that those are becoming increasingly available. They're still not ubiquitous. And if you look at the paper that comes out next month, you can see that we don't go so far as to say that we're recommending that that test is checked prior to giving a reversal agent. I think that recommendation could change in a few years. I think those tests are becoming increasingly available. And you can imagine a scenario where you have a poor historian or a no historian. So someone intubated in the field after a fall, families nowhere to be found. You find that 10A inhibitors on their med list, and there is some bleeding. You don't know kind of when their last dose was, if they've been non-compliant with their meds. And we'll talk about it in a little bit, but there is risk to giving some of these reversal agents, right? Risks of thrombosis, there's costs associated with them. And so if the 10A activity in that patient is very low and it's metabolized, then there could be no benefit in giving that reversal, and you may want to know that. And so again, not currently widely available, and there is a delay that is required to get that test back. And so that delay could, in a patient with active drug, lead to a delay in getting the reversal agent, which again, in a high mortality situation, you don't want to delay access to that drug. And so I wouldn't go so far as to recommend that now, but that's kind of an area to watch in this field. You may see PT-INR for rivaroxaban being somewhat helpful kind of qualitatively, but otherwise not terribly helpful for PT-INR and PTT for the 10A inhibitors. You might use the eCarrin clotting time for Pradaxa, but that's, again, not something that we typically order from the emergency department or use for clinical decision making. Let's dive in a little bit into andexanet alpha. I kind of teased this earlier about what it is. It's a factor 10A decoy. So it's a protein that's meant to look like factor 10A, and it reversibly binds to 10A inhibitors, right? So the 10A inhibitor will be kind of bound up by this andexanet alpha, and it's given in a bolus plus an infusion. And so during the time that the drug is actively going into the patient, then the 10A activity really falls off, but then it creeps back up after the infusion ends. And I'll show you a chart that kind of illustrates that. And then again, there's not indicated for emergency surgery at this point. The main study that led to the approval in 2018 for commercial use in life-threatening bleeds of andexanet alpha is the ANNEXA-4 study. there's a lot written around kind of the pros and cons of this particular study. Some of the aspects of the study that's kind of worth mentioning is that it was single arm. So it was not comparing directly andexanet alpha to PCCs. All the patients got andexanet alpha. And then in the lower left, you can see that they did exclude some patient populations that in real life would be getting andexanet alpha, right? And you can imagine they might be having worse outcomes. So larger volume head bleeds, patients with very low GCS scores, et cetera. And then they follow these patients out to 30 days to look for safety events such as thrombosis. And what you saw, like who made up these patients, the safety population was everyone, and then the efficacy population was the subset who had kind of active factor 10A drug in their system above a certain threshold. And they found that most of these drugs were intracranial, most of these patients were intracranial bleed patients. And then the second most common, about a quarter of them were GI bleed, and then the kind of 8 to 10% was the other category. And these are kind of that other cortical sites that I mentioned, gave a few examples of, such as the spine or aorta. And so you can see mostly two groups of patients, the intracranial hemorrhage and GI bleed, that's been studied. And I mentioned about dosing. So andexanet alpha comes in basically two flavors of dosing, a low dose and a high dose. And that's going to be based on when the 10A inhibitor was last taken and what the dose is. And so regardless of the dose, if it's been 8 or more hours, then it's the low dose andexanet is what you're going to give. And then if it's been within 8 hours, then you want to know the actual dose of the apixaban or rivaroxaban. And then you would base the high versus low dose. So this table, given that you probably aren't going to give andexanet alpha as frequently as many other drugs in the emergency department, should be kind of hardwired into your EMR or into your reversal policy, because it's kind of a low incidence, high importance action, and you want to get the dosing right. This is where your ED pharmacist might be able to help you as well. I mentioned before this kind of graph of factor 10A activity and what happens to it when you get the initial bolus and infusion of andexanet alpha. And so if you look at the green line, you can see that when the bolus is given, kind of rapidly decreasing factor 10A activity, and then it stays low, and then there's a 2-hour infusion. Once that infusion stops running, you can see that the activity kind of rebounds up. You can see that the red line is placebo, right? So, and I mentioned before that these drugs are metabolized and excreted over time as well. So you'd expect that red line to drop off as well, just with no treatment. And the idea is that you're, in a patient with life-threatening bleed or a critical site bleed, you want to buy them time for coagulation to happen, for interventions to happen, for them to get out of this danger window where death or disability is likely or is a high concern. So how did the patients do in XO4? Well, most of them had what was classified as either excellent or good hemostasis. And so these are adjudicated outcomes. So we had, people reviewing cases and then making classifications based on preset definitions, and they agreed upon these outcomes. And so it looks like 82% going to fit into one of those two categories. Again, patients still had bad outcomes despite getting andexanet alpha, but many fewer of them than in the kind of pre-andexanet alpha time period in other studies. Now, again, we're not. This study is not looking directly at andexanet alpha versus PCCs. So thrombosis is worth. I have a couple slides on thrombosis. So that's, we talked about the sweet spot of preventing thrombosis and preventing bleeding, right? And so one of the risks of reversing a patient, either with anything. And so in the bottom, you have risks with thrombosis with PCCs or duracizumab. On top, we're looking at the thrombotic events for andexanet alpha. These are all different studies with different inclusion and exclusion criteria. So we're kind of comparing rates of a similar outcome across different studies. And so from a journal club perspective, that's kind of a no-no. So, but we need some basis of comparison. So you can see that there's this non-zero rate of thrombotic events, right? And so most of these are happening in the period of time before anticoagulants have been restarted for these patients. they were on a blood thinner for a reason, right? They had an increased risk of thrombosis. Now put them in an ICU where they're immobile, they're bleeding, they've been given a reversal agent, and they're going to have some thrombosis as a consequence of that. And it's really in this gap before anticoagulation has been restarted. For this looking closely, a little more closely at the thrombotic events in the Annexa-4 trial, there were none after oral anticoagulation was restarted. So they all happened either with no anticoagulation or after like a parenteral anticoagulant like subQ heparin was started. I mentioned before we don't have a direct trial looking at PCCs versus andexanet alpha. This is a kind of recent study from the spring looking at propensity score matching across a different data set, trying to compare similar patients who received PCCs versus andexanet alpha. And those are the two left columns are going to show you what the mortality rate is in the whole cohort who received PCCs versus the cohort who received andexanet alpha. And then they break it out into the intracranial hemorrhage subgroup and the GI subgroup.